We are live now, so we can start the session. Yeah.
Good evening, everyone, and a warm welcome to you all to the 6th Minto Vitro Retina Alumni CME on Diabetic Retinopathy, powered by Microvision, in this landmark year of Minto's 125 years anniversary celebrations. Firstly, I would like to welcome our beloved Director of Regional Institute of Ophthalmology, Minto Ophthalmic Hospital, BMCRI, Professor Dr. B.L. Sujata Madam, Head Community Ophthalm, and Organizing Secretary for the CME, Professor Dr. B.N. Kalpana Ma'am, Head VR, Medical Superintendent, RIO, Minto Ophthalmic Hospital, BMCRI. It's their constant enthusiasm and efforts that the CME is happening every year. Our ever dynamic ladies need no further introduction, as you all know. I welcome all the speakers, my seniors, colleagues, and fellows and PGs. Our topic for discussion today is diabetic retinopathy, which you know is as huge a pandemic as COVID-19. Giving it all due respects, we have today with us some of the most eminent speakers and teachers and VR surgeons across the country, along with whom we can dive into this vast ocean that is diabetic retinopathy. We have 3 sessions tonight covering topics from screening camps to artificial intelligence in it, various biomarkers, surgical indications, complications, and complex surgical managements. I would like to take this opportunity, steal a minute more of all yours to highlight the Vitro-Retina department at Minto. So the VR department at Minto is working hard and thriving ahead higher every year under our ever dynamic VR head, Dr. B.N. Kalpana Ma'am, and also supportive pillar in all our endeavors, our director and VR surgeon, Dr. B.L. Sujata Madam. We are currently working with 2 retina units catering to retina patients at Retina Clinic and Retina OT daily. On an average, yearly 25,000 retina patients are visiting us. We are providing all the services, B-scan, fundus imaging, FFA, OCT angio, therapeutic lasers for all retinal indications. Also, retinopathy of prematurity. ROP screening, RETCAM imaging, and treatment as required, done on regular basis. On an average, 700 vitreoretinal surgeries being done annually, including emergency surgeries for endophthalmitis, intraocular foreign bodies, RD surgeries, surgeries for diabetics, macular hole surgeries, dislocated lens, IOL, using high-end Constellation and Appasamy vitrectomy machines. Not falling behind in academics, we have 33 publications in national and international journals, 120 citations with postgraduate paper presentations at state and national levels. We aspire to reach higher under guidance of Professor Dr. B.N. Kalpana Ma'am. Thank you, Madam, for giving me this opportunity today. I welcome all of you again on this wonderful eve. Let us take off with session 1. I invite the moderators, Professor and Unit Chief Dr. Shashidhar Sir and Assistant Professor Dr. Ravi B. Over to you, sir.
Good evening, everyone. Today I have the opportunity of introducing the first speaker of today's session. Professor Sujata Rathore Ma'am. She'll be speaking on diabetic retinopathy and overview and screening camp. So ma'am has did a master degree from Bangalore Medical College in the year 2006, and she has a MSc Community Eye Health from International Center of Eye Health. It's attached to Moofield Eye Hospital, and presently she's working as a director, head of the Department of Community Ophthalmology, Regional Institute of Ophthalmology, Bangalore Medical College. During masters at Moofield Eye Hospital, she was associated with the Professor Alan Bird with regard to retinal degeneration, and she was part of retina team to be trained by Dr. Hilton during his visit to Bangalore. Ma'am has authored book in AOS CME series on age-related macular degeneration in the year 2011. She has vast experience, academic experience. She was a member of a board of many studies which were started from Rajiv Gandhi University of Health Science. So she is member of board of studies of undergraduates and postgraduates. She was a member of University Senate member. She has got academic experience of more than 3 decades and community service of 27 years. And she has served as an administrator in various levels as head of the Department of Minto Regional Institute of Ophthalmology, medical superintendent, and presently as director. Professor Sujata Ma'am is member of All India Medical Association, and she is member of various ophthalmic associations like Karnataka, AOS, All India Ophthalmic Society, Vitro-Retina Society of India, and CAMHAT. She has received many awards and achievements. She has a lot of achievements. To name some, she has received a letter of appreciation by Her Excellency Srimati Ramadevi, former Governor of Karnataka, and she received a best prize for presentation on study of 17 cases of traumatic endophthalmitis. To name, there are so many awards. She received a Professional Excellency Award in Education in the year 2015 and a Nobel Award by Sri R.V. Devraj Trust in the year 2018 and Lions Professional Excellence Award by Lions Club in the year 2018 and ACON UP State Chapter Oration Award in the year 2019, Channel Green and Cassia Women's Excellence Award in the year of 2021 and Bhimapuri Bhimaputri Brigade Savitribai Phule Award in the year of 2021. To name, there are a lot. Because of restricted time, I welcome you, ma'am, for the evening session. So, ma'am will be speaking on diabetic retinopathy and overview and screening camps. Thank you. Over to you, ma'am.
Yeah, a very warm good evening to one and all, and greetings from the 125th year institute. Warm welcome to all the eminent faculty and the participants for this academic program on diabetic retinopathy. At the outset, I am thankful to the team Retina at Minto, Dr. Kalpana and team for making me a part of this meet to speak on diabetic retinopathy, overview and screening for diabetic retinopathy. Screening, as all of us know, let's come to the, is it visible, the screen? Is the screen visible?
Visible, ma'am.
Ma'am,
Visible, madam, visible. Yes, ma'am.
Slides, yeah. So,
Ma'am, you go to full screen.
You can go to the slideshow, ma'am.
Yeah, slideshow.
You can go to the slideshow, ma'am.
I am in the slideshow.
Ma'am, you go down on the presentation screen,
Yeah,
and you see on the right side there is a sign of cup-like sign, ma'am. On the right side down. Can you take your cursor there?
No, I can't see anything there.
Absolutely down, ma'am. Absolutely down. There is something written 77%.
No.
Exactly down on the right side.
Is it seen now?
Ma'am, it's seen, but it's not fully screen.
I'll go from, yeah, slideshow. Now?
From beginning is the normal, we can.
Is it seen now?
No, madam, you better stop the screen share and share it again and try.
I think now it's visible, right?
Full screen, not at a come.
It's visible, ma'am, but you have to go for full screen.
Full screen.
Done?
Ma'am, you just click on from beginning, ma'am. You are in a slideshow. The left-hand side says from beginning is there. Just click on that this icon, ma'am.
Nothing is coming on my screen.
Top left side.
Madam, there is something written as resume slideshow. Can you click on that?
Yeah.
I did that.
Or else close that, madam. Close that slideshow mode. Yeah. Now you go back on the right corner just beside 77% and then you click and try. Left side, madam. Just beside the 77%. On the right bottom corner. Left side, just left to that. Yeah, just left to that 77%.
Okay.
No, not that, madam. You are zooming in. Just left to that 77%. Do you see one icon there?
Yeah, that's the slideshow. Yeah.
Just press it and see.
I pressed it.
So it's not coming.
There?
No, ma'am. The full screen mode is not coming. I think you can continue. If not.
I'm so sorry. I think you start off with some other.
Go ahead with the presentation, ma'am. No problem.
Ma'am, no issue, ma'am. The slide is visible clearly. You can go ahead, ma'am.
It's not visible to you all?
Yeah, it's
No, visible,
ma'am.
ma'am. Visible to everyone.
Okay, let me just go.
Yeah. Go from the first slide.
Yeah.
No issues now.
Yeah, very warm good evening to all. Sorry for the initial hiccup. I think as all of us know, diabetes is just the tip of the iceberg. What we know about diabetes is just the tip of the iceberg. There's a huge population which are still undiagnosed, and so also comes with its problem of diabetic blindness. Diabetes in India too is a huge burden, and very soon we are going to be called the diabetic capital of the world, because by 2030, according to the estimates, 8.4% of India's adult population will have diabetes, and the prevalence has increased from 7.1 to about 20% in 2019. As all of us know, I is one of the...
Sorry to interrupt, ma'am. We are not seeing your first slide.
Now?
We are seeing your 11th slide. Please go to the first slide and then talk.
This was the first slide. It's not seen?
No, ma'am, it's showing 11th slide.
We are seeing the 11th slide, ma'am.
Something is totally wrong, I think. Okay, let me just go on. The diabetes, as all of you know, is one of those, eye remains one of those end arterial systems where diabetes affects, and people go blind with the various complications which occur because of its proliferativeness. And so diabetic blindness remains a challenge because of the ocular symptoms being too late, and the rising numbers of people with diabetic retinopathy present several challenges in awareness creation, the screening and service delivery, and capacity building in the community is the only one which can help in looking at this problem at large. Diabetic retinopathy is one of those conditions where a specific microvascular complication occurs, and it affects 1 in 3 persons. And with the progression of diabetic retinopathy, we see that the quality of the life also of these patients decreases, and so also they become a huge burden to the family and society. If we look at the United States too, there's going to be a global bloom and a global doom with regard to diabetic retinopathy, where by 2040, it's considered that about 70 million population will have vision-threatening diabetic retinopathy findings. And in India too, it's a major cause for concern because of the associated comorbidities of hypertension, obesity, and greater degree of family history in diabetics. And not only is it seen in the affluent in the urban India, but we have also seen that it is highly prevalent amongst the poor in the urban and in the rural areas. The prevalence of sight-threatening diabetic retinopathy, that's severe NPDR, PDR, and CSME, has shown to be about 3.6%, and we need to take care of this in order to take care of this diabetic retinopathy problem. As we look the cycle or the major risk factors, as mentioned earlier, we have to look at the various comorbidities that are associated with it, besides looking at pregnancy, where again diabetes can, pregnancy itself can be triggering of diabetes. So when we get a patient of diabetes, we definitely go in to look at the detailed patient history with regard to their diabetic age, their good glycemic control, the various medications which are used, whether it's just oral tablets or they're on systemic intramuscular medications, systemic history associated with any of the comorbid conditions of hypertension and lipid levels being high, and a detailed ocular history. Initial physical examination will not be complete without the detailed evaluation of the visual acuity, recording the IOP, and looking at the anterior segment through gonioscopy or slit lamp biomicroscopy for any features of neovascularization, and fundus examination, of course. Without dilated pupil examination, it is never complete, and so also the retinal photography and documentation. Various ancillary tests are a must in every ophthalmic vitreoretina clinic, be it with the fluorescein angiography. And as all of us know, OCT has become the most sensitive method to identify sites and severity of diabetic macular edema. After understanding the various stages of diabetic retinopathy.
Sorry to interrupt you.
Yeah.
You can just press the 12th side seen on the left side. You can keep clicking on that. That will display it.
Which one?
You see on the left side, you see those 11, 12, 13, 14 slides, right?
Slides. I'm not seeing the numbers at all.
Okay. Okay.
It's not just getting displayed.
No, ma'am, it is only that detailed ophthalmic assessment. In that slide only it is stuck.
You press escape. So probably you will get back the original screen, and then you keep on clicking on the manually on the left side instead of clicking the arrows.
Ma'am, can you try F5, ma'am? F5.
Now?
No, ma'am, it's stuck at 11th slide only.
I don't know. Is it seen now?
Yeah.
Yes, madam.
Yes, ma'am. Yeah, it's at the 11th slide. We can go to the next. Yeah.
Now it's full screen also, ma'am. It's coming out nicely.
Okay. So basically, once we analyze the various stages of diabetic retinopathy, the logical end to complete care would be to make them realize when they need to come for a routine re-examination or for referral and follow-ups. And this is the follow-up schedule which is given for in our Indian context. When there is no apparent diabetic retinopathy, a routine annual evaluation. With mild and moderate, again annual evaluation, but with involvement of the macula, we go in for a 3-monthly evaluation, and the other treatment protocols when we look at severe non-proliferative DR and proliferative DR. So in order to have a healthy cycle which can keep the diabetic retinopathy or the retinopathy blindness a challenge to us, we need to have this particular cycle. That is, screening is extremely important with early diagnosis, wherein we can go for prompt treatments, considering all the modifiable systemic risk factors, very strict follow-up. And of course, for the society, we need to educate and create awareness so that they have a health-seeking attitude towards the whole problem of diabetic retinopathy. So diabetic retinopathy as a health problem adheres to all the principles of screening. And as we know, screening is that process wherein we pick up a unrecognized defect by means of a rapidly applied test in an apparently healthy individual. So diabetic retinopathy, because of its long latent phase and being a chronic disease, needs to be, its screening is found to be beneficial at every stage of this disease, and it is helpful to avoid blindness amongst 90% of patients. So when we look at the community care for diabetic retinopathy, it is to understand that the goal is to have a cost-effective, preventive, easily accessible and sustainable diabetic retinopathy care with inbuilt components for awareness creation, service delivery, and capacity building in the society. So this, the point of care should be located closer to the rural community for its compliance. As we've already mentioned, since the sight-threatening diabetic retinopathy is apparently on the rise with the population of diabetics becoming more, we need to prevent this blindness by promptly identifying and treating. And screening modalities are relatively simple and most cost-effective. And as ophthalmologists, hence it is essential that not only we look at the timely assessment, detection of this sight-threatening lesions, but put appropriate protocols and educate individuals with diabetes regarding their eye conditions and what can happen if they do not take prompt care of their eyes. And one more important thing is, besides educating the population about the diabetic problems, we need to also train our trainers like the physicians and get the other members of the society to be part of this diabetic care, like the Anganwadi workers or the grassroots workers who can have a better influence at the community level. So the goal of this diabetic care at community would be to identify patients at risk of developing diabetes diabetic retinopathy and treat those who are at risk. And those we cannot treat, definitely refer them to visual rehabilitation services. So what we have seen, the majority or the major challenges in diabetic screening is with regard to the knowledge a community has on this diabetic disease, and the attitude and the practices towards it. Just to run through various studies which I've looked into these three aspects. A South India review study in one of the major hospitals showed that only 20% knew that diabetes was a risk factor for developing of diabetic retinopathy. And in one of the Chennai studies, it showed that 63% of the rural and as well as 75% of the urban diabetics never ever had a eye evaluation for diabetic retinopathy. There are multiple myths associated to diabetic care where they think that every vision loss or every symptom has to be associated with vision loss, which is not so. And so again, another study showed that only 42% had good knowledge about diabetes, but they were unaware about diabetic retinopathy. And a total of 61% did not even know that a periodic examination were needed for the follow-up. In our own Minto study done by our retina department in the year 2017 to 19, where about 622 participants were interviewed, it was seen that a whopping number of 55% were not even aware that the separate type of evaluation and treatment was necessary for diabetic retinopathy, and 74% were unaware that they needed to be followed up. This study also made us again emphasize that there's a huge need for the importance of education and to increase awareness of this disease amongst the diabetic population. And since we had many of them come with advanced diabetic retinopathy stages with multiple drug regime, it definitely demands that early screening can prevent this visual morbidity. And one simple take-home message should be that fundus examination, dilated fundus examination as a routine, the minute a patient is diagnosed with diabetes, will go a long way in picking up the earliest signs and symptoms and in taking care of the condition. Just to run through this particular, in literature review, I got this article which spoke about the various screening modules for rural population in India. We have various modules, and the most commonest thing which all of us do are the opportunity screening modules to the diabetics who come to our clinics. But in the community, we can have essentially mass screening places, diabetes screening camps, and again, diabetes retinopathy screening camps to identify the various stages and to identify who has to be referred and who has to be routinely reassessed. Comprehensive eye screening camps where we go in for our cataracts, glaucoma, and other things can also be a good screening place for diabetes and diabetic retinopathy. And currently, diabetic retinopathy screening approach has found to be extremely useful in our country in the various community setups of our various eye hospitals in the country. So when we go to the population, anybody who is more than 30 years with a simple glucose oxidase method of random blood sugar being tested are put into diabetics and non-diabetics. And if they are diabetics, again, they are further recruited to the diabetic retinopathy screening camps where a comprehensive eye examination, including the recording of the blood pressure, height, and weight for calculation of the basal metabolic index is done. And those with sight-threatening diabetic retinopathy are further referred to the secondary and tertiary care centers where diagnostic evaluations and treatment protocols are in place. But those without any fundus changes are only advised and followed up as we have earlier discussed, whether it's annual, 3-monthly, or more rapid follow-ups as the stage of the diabetic retinopathy is identified. So as you all know that we have 3 levels of healthcare system in our country. And so at primary level, all they can do is just identify these diabetic patients from the community and then have the knowledge that they have to refer them to the secondary or tertiary. Secondary level, depending on the trained ophthalmologist, if they are vitreoretina people who are trained, they can look into the fundus evaluation and they can diagnose and categorize which is a mild to moderate non-proliferative diabetic retinopathies or proliferative diabetic retinopathies, which can be further referred. And it's at the tertiary level where all the important modalities of diagnosis and treatment is seen through our fundus photographies, fluorescein angiographies, OCTs, and the available treatments of laser, then the various pharmacological interventions, and of course the surgical interventions. So a screening guideline should essentially identify who should be screened, who should screen this diabetic population. And besides ophthalmologist, even the physician who's aware can be made part of this screening protocol. The optometrists or the ophthalmic assistants who have had adequate training and who are engaged in screening and looking at the fundus to pick up the findings, or any field worker who has had a good 3-month training in identifying the features of diabetic retinopathy. Whom to screen? Of course, it's always the people with known diabetes, which can be done as opportunistic screening or as mass screening. And the methods which are used to screen are multiple. Indirect ophthalmoscopy with a dilated evaluation is again one of the most simplest way to pick up findings. But in the periphery, of late, we have seen that the handheld fundus camera has been found to be extremely useful, and the use of images, acquiring images and sending it through smartphones has been the norm of the day. But at all times, digital photography of the fundus remains the most efficient and effective way to do the screening. So these are just to run through the various methods of tools which are used in screening, be it at the field level or in the institutional levels. And simple reference guidance are that if the screening area does not even have a way to look at visual acuity or retinal examination too, they just need to refer to the next level of ophthalmologist. But if they are able to identify that the visual acuity is below 612 and has symptomatic vision complaints, they need to refer it to the secondary or tertiary centers. And also it is important that they identify patients who have already had treatment to be routinely re-evaluated. So that's the protocol as to annual review, routine referral, early and urgent referral in cases of all high-risk PDRs. So need of the hour is being this community-based screening modules, and the aim is that it should it should be an extended service from provider hospitals like us, and the aim would be that we should take this sort of evaluation to the doorsteps and try to involve the community, the various organizations, in order to create diabetic retinopathy awareness. Because only when we can adequately link all these people, be it physicians, diabetologists, village-based RMPs, the Anganwadi workers, self-help group women, we can create a society which can look into who can be aware that there are, first and foremost, that the disease can end up with such severe sight-threatening conditions, and that they should be aware that treatments are available and where they can access these treatments. So this is just a few more other points which is working out in our own the government. There's one day which is fixed in most of the PHCs. Thursday is identified as a day to screen diabetic retinopathy at the PHCs. Preferably mid-reatic diabetic screening is recommended. But many of the places, this is already in place, where the primary ophthalmic assistant, with the help of a low-cost fundus camera, takes the images and sends it to the base hospital for opinion and further management. In order to take it more and more to the places where it's not accessible, where health services are not accessible, again, there's a mobile van approach where most of the diabetic screening tools are fitted in the machine, and also basic treatment like the laser delivery system, a portable delivery system, or the planning to take intravitreal injections is also made in this particular van approach. Further important thing is that as part of the national programs, educational strategies to update on diabetes and diabetic retinopathy is again always encouraged, and to encourage fundal evaluation for all diabetics remains the norm of the day. And when we look at patient education and creating awareness, it's extremely important that they should be made to realize that the disease has a severe course if it's untreated and undiagnosed. And also that they should keep a constant communication with their general physician to look at the other comorbidities and educate them about the importance of maintaining their near normal glucose, near normal blood pressure, and to control their serum lipid levels. So the key messages would be about disease and its complication and the need for preventive care, and to look at how it can have repercussions on the society as a large. So I think all of us know about this. AIOS through its teleopthal has tried to bring about this initiative of screening through teleophthalmology. And the birth of this initiative was the imbalance of ophthalmologists and optometrists throughout the country. And also it looked at semi-skilled workers who can easily pick up these photographs and send to centers which can give the opinion. So optometrists should take charge of this primary eye care, and semi-skilled workers can also be roped into bring about the process of screening so that ophthalmologists can look into more serious management protocols. So this is how it is. The telehealth practice recommendation for diabetic retinopathy has 4 components of image acquisition, image review and evaluation, patient care supervision, image storage and data storage, and opinion. And to add to it, the Remedio Innovative Solutions in Bangalore has also brought about this fundus on phone device, which is easily can be used by the health workers, and the messages can be sent to the tertiary centers for opinion and management. To run through our own screening overview, we have been doing community outscreen programs from the last more than 7 to 8 years, and cover these 2 areas of the Ramnagar and Chikbalapur districts and its various taluks. And we provide, periodically twice a month, we go to these setups, and our team has 2 ophthalmologists and a camp coordinator. And the equipments they essentially take are the IDO, and we have a health educator who goes to create more and more awareness on the disease. And initially we did have our portable slit lamp or portable fundus camera, which used to be shifted there. But the problems we faced at grassroots level was that there would not be adequate electricities, or we would, and the cost of the repairs of these machines, because the transport itself would cause a lot of damage to the equipment. So when we weighed the pros and cons, it was much more easier that we could get the patients in our vehicles, do the necessary treatment, free treatment at the regional institute, and send them back. So this sort of protocol has been going on with us, and we have many vision centers where we have lined up to do the teleopthal screening too. And the numbers we have so far seen are about 1,500 diabetics, and this fundus cameras, the Remedio fundus camera is in use with us, and we have treated about 330 diabetics through our camps. And the prevalence which we have identified in this rural area also is as high as 21%. And the various campaign materials are always taken. To end up the topic on screening for diabetic retinopathy, of course, artificial intelligence cannot be left behind at all. It's very much a step forward for application of this technology in mass screening and looking at timely diagnosis. Details of this is definitely going to be spoken by a lot of other speakers in due course. And so this artificial intelligence, it's with its IDX and DR technology has been put in use from a few years now, with a high grade of sensitivity and specificity. This is here to stay and to help us to look at our patients at a very early, for early evaluation and management. Diabetic retinopathy still remains a major problem because we have very limited centers and also limited retina specialists who are trained to diagnose and treat diabetic retinopathy. So this is definitely needed to be looked at what political will and the health makers who have to look into these things, so that we try to have or achieve timely diagnosis and medical attention to these conditions. And also accessing the rural population still remains a big challenge. But as I showed earlier, having mobile vans, not just for cataract evaluation, but to look at this severe grade of diabetic blindness, we need to have those sort of modified vehicles which can reach every doorstep of the rural population. And as on now, telemedicine still remains one of the most convenient methods that can be utilized to promulgate awareness as well as to diagnose these diseases such as DR. So for early identification of this condition, we need to have various, it has to be supported by various referral structures, and we have to streamline these modules in our existing health structures with public-private partnerships and involvement. So as ophthalmologists and as vitreoretina surgeons, I think all of us identify that the primary purpose of evaluating and managing diabetic retinopathy is to retard or reverse vision loss and thereby maintain or improve the vision related life of these patients. Thank you, and sorry for the disturbance sorry for not being able to share the screen earlier. Thank you.
Thank you, ma'am. Thank you for giving an insight about screening camps and managing diabetic patients. As all of you know, 30 years before, diabetic retinopathy was one of the 17 causes of visual loss. Now it's become one of the 6 causes of visual loss. So as I told, early detection and treatment is the choice, and we have to educate general physician, general population, as well as diabetologists to refer cases when they diagnose diabetic retinopathy. It's seen that most of the cases they will go with the medication and they won't come to ophthalmologist. So we have to give a guidelines to diabetologists and physicians to, once they diagnose diabetes, better to see an ophthalmologist at the time of diagnosis itself. Thank you, ma'am.
Thank you.
So next speaker of today is Dr. Srinivas M. Joshi. He is a practicing vitreoretinal surgeon and director for research and community services at M. Joshi Institute Group of Hospitals, North Karnataka. After his post-graduation from Jain Medical College, Belgaum, he pursued his surgical fellowship in vitreoretina from the University of Toronto, North America. He is also a fellow of American Society of Retinal Specialists, FASRS. He is presently serving as AOS ARC Member South Secretary, Karnataka Ophthalmic Society, Secretary IS MSICS, Section Editor for Retina in Indian Journal of Ophthalmology. He has been part of various clinical trials conducted in India and abroad, and has been an invited speaker at international and national conferences. His keen interest in postgraduate training and has conducted many teaching schedules. He has received various awards, to name a few: recipient of Senior Honor Award by American Society of Retinal Specialists, Boston in year 2017, recipient of prestigious Red Buckler Award for the Best Video by American Society Retina Specialists, that is ASRS, for 5 consecutive years from 2017 to 21, received International Hero Award by All India Ophthalmological Society from the year 2018 to 21, 4 consecutive years, and gold medalist by AIMS Rishikesh, Bombay Ophthalmic Association, IRIS Chennai, and Young Achiever Award by Vidarbha Ophthalmic Society. Area special interest: artificial retinal processes, macular surgeries, and pediatric retinal surgeries.
Thank you so much.
Will be speaking on ultra-wide field retinal imaging and its role in diabetic management. Over to you, sir.
Thank you very much, Swami sir, for this kind introduction. So today I'll be speaking on ultra-wide field imaging in diabetic retinopathy. So first of all, I would like to thank each and every one of you at the Minto Ophthalmic Hospital, which is considered to be the apex center for ophthalmology in Karnataka. Thank you so much, Kalpana Madam, Dr. Hemlata Madam, and Dr. Sujata Madam for this kind invitation, and I deemed it as an honor to be part of this prestigious meeting. So I have no financial interest in this presentation. We all know, I think, Sujata Madam has covered it in vast way, that how the diabetic retinopathy is becoming a burden, and we all know that India is the diabetic capital of the world. So coming to the peripheral predilection, it's the centripetal progression that is often underestimate the need for peripheral retinal examination, especially in the case of diabetic retinopathy. So the progressive capillary remodeling and the non-perfusion selectively favors the peripheral retina. So the ultra-wide field is defined by the Diabetic Retinopathy Clinical Research and Research Network, that is DRCR net, as a field of view of more than 100 degrees. So this is how you can see with a 30-degree lens, with a 55 degrees of lens, and this is the ultra-wide field view of the fundus. So ETDRS 7 field, as we all know, it only covers about 75 degrees. With a red cam, you have 130 degrees. With a Heidelberg non-contact, you have 110 degrees. But if you attach a Strarangi 230 lens with that, then it gives you a wider view of 150 degrees. But the king of that is the Optos, which gives you around 200 degrees field of view. So this is the 7 field as described by the ETDRS, and this is the extended field. I'll be coming to it a little later. So this is how it looks on the fluorescein angiography. This is the 7 standard field, but the most important you're missing here is the non-perfusion in the peripheral area. So the 2 major players here are the Optos and the Heidelberg Spectralis. And we all know that the Optos gives around roughly, theoretically, the company says it gives around 82.5% of the total surface of the retina. And the most important in these is, especially in the Heidelberg, is the CSLO, that is the confocal laser scanning ophthalmoscopy, which improves the resolution and the pixelation of the images, especially in the fundus images or the angiographic or the ICG images what we obtain. So these are the few basic differences between the two. We all know it gives 200 degree, but Heidelberg gives around 102 degrees field of view. The only disadvantage with the Optos is sometimes if the technician is not very well trained, the lid and the lash artifacts, they distort the peripheral view. And here, of course, as compared to the Optos, it has lesser field of view. So since these years, you say finding of this standardized 7 field, the 30 degrees fundus photographs of the posterior pole has remained the gold standard, but the composed of the overlapping 30 degree circles, which says that the extent of 75 degrees horizontally and 70 degrees vertically. So UWF, the image acquisition is reduced patient compliance, and the peripheral field is obtained is much better. No montage artifacts, multiple areas can be captured with the FA. Here you can see the conventional FA with around 35-50 degrees field of view, but with ultra wide field, you can definitely have a larger field of view in the ultra wide field angiography. So there's a paper which says that the Talks et al. Showed that the Optos ultra wide field image detected approximately 30% more peripheral neovascularization than the standard 2-field imaging in the patients. And in another paper, they say that 20% of the eyes had diabetic retinopathy grade severity discrepancies, with 10% having higher grade of DR on UWF. And 1/3 of the lesions were actually outside the ETDRS 7 field. There's another paper published in American Journal, which says that the peripheral ischemia and the leakage correlates with the macular ischemia, which further correlates with the visual acuity and development of PDR. However, there have been a lot of controversies on this. In one of the paper presented in ARVO 2018 meeting at the Honolulu, Hawaii, which says that the ischemic index is basically the area of capillary non-perfusion divided by the total retinal area. It was not associated with the DME, but definitely was associated with the progression of the diabetic retinopathy. So here the Patel et al. Showed that the presence of these non-perfusion areas, it basically favored more of recalcitrant diabetic macular edema. So the ultra wide field images were graded for the quantify of the non-perfusion, and which was used to calculate the ischemic index. And eyes with a larger area of retinal non-perfusion, as you see here in this field, has the greater severity of the DR, were found to have the most recalcitrant DME, was what described by this paper. So this is how you can see the various views here in the case of fundus for color photograph, in the angiography, where you can sometimes miss these NVEs or the non-perfusion areas. And so you can see here with the ultra wide field fluorescein angiography reveals significantly more retinal vascular pathology in patients with DR, and improved retinal visualization may alter the classification of diabetic retinopathy itself, and may therefore influence the follow-up and the treatment of these patients. So in the interesting paper, the Vessel et al. Described that with the UWF, you can see 3.2 times the amount of the retinal area more as compared to the standard 7 field, 3.9 times the amount of retinal non-perfusion, 1.9 times the area of neovascularization, 3.8 times. So as you compared with the simulated 7 standard field, I think this gives a slightly better as per this paper. So by targeting the PRP directly to the areas of ischemia rather than doing it in a healthy retina, so this paper described that they may be able to spare the healthy retinal tissue and reduce the side effects of the PRP. So this was what described by Silva et al. This here you can see this is the standard 7 field, but he described another extended 5 field with ultra wide field, saying that in any of the 5 extended fields demonstrated more DR lesions compared to its corresponding ETDRS field. They deemed the eye to contain PPL. So what is this PPL? It's nothing but the predominant peripheral lesions. So this is defined as the hemorrhages, microaneurysms, venous bleeding, intraretinal irma, and any new vessels elsewhere with more than 50% of the graded lesion located outside the ETDRS field in each of these 5 extended fields. So this is the 5 extended field using ultra wide field. They have described it. So they also found out that the presence and increasing extents of PPL lesions were associated with increased risk of progression of DR, although the baseline, what I mean to say is the independent of the baseline DR severity and even the HbA1c levels. So this was very interesting to look into it. So coming to the ultra wide field and the TRP, that is the targeted laser photocoagulation, targeted PRP to the ischemic area will definitely decrease the ischemic drive and ultimately reduce the retinal vascular leakage and DME. So in combination with the anti-VEGF, definitely it enhances the ability to elevate the DME. So the effect of TRP on PDR, this paper found out that the regression was seen in 76% of the patients at 12 weeks, complete disease regression in 37% and partial regression in 33%. So the same group conducted a randomized clinical trial, compare the effect of TRP, that is targeted laser, compared to the standard pan-retinal photocoagulation. And they found out that a significant reduction in the central retinal thickness was found in the TRP group and rather than in the minimally traumatic PRP group. So coming to the UWF and the PDR, we all know that there has been a plethora of the studies being done on these anti-VEGF, RISE, RIDE, VISTA, DRCL, B, H, I, N, T. But the role of ultra-wide field FA in identifying the peripheral non-perfusion other pathologic changes is being assessed in the ongoing protocol AA of drcl.net. I think the results will be very much interesting and we are all waiting for that. So these are the few case examples where we captured it and we saw that the neovascularization in the periphery helped us to treat these lesions and ultimately decrease the VEGF load and decrease the number of injections for the DME. So this is the another case. The left eye was having a vitreous hemorrhage, but the right eye, you can see this the peripheral neovascularization, which helped us to add more fill-in PRP and thereby decreasing the VEGF load. So coming to the last few slides of mine, ultra wide field and the recalcitrant DME. I think this is one thing which is very, very important because sometimes the patient do not respond with any of these, like either the focal, grid, macula, intravitreal injections, including the steroid lasers, the steroids or any of these longer acting anti-VEGF. So the pathology, what they claim is to be lies in the peripheral ischemic retina, and the ultra wide field may give an insight on this and make existing treatment more efficacious. So the Vessel and associates showed that the peripheral retinal ischemia is significantly correlated with DME in treatment-naive patients with DR using ultra-wide field imaging. And lastly, ultra-wide field and AI, I think Thiru will be covering more about it. I think this is very, very interesting. The ultra-wide field with the AI, they're detecting it and telling the patient, the physicians, especially when they ping it, because as madam said, the most of these Remedio machines are being sold at various physicians' places, and they are now being inculcated with AI. I think that will be bringing more referrals to the vitreoretinal surgeons so that the treatment burden, the effective treatment is given at the proper time for these patients. So only the limitation here, what I see is the most peripheral areas can appear magnified up to 2 times the posterior pole, and the horizontal axis seems to be artifactually stretched as compared to the vertical axis. So these are the one of the major limitations of these, and of course the cost is also important to be thought of. So to conclude, it's a easy, obtainable, high quality imaging that can assist in identifying and better understanding, especially in knowing this disease, knowing more and more of the periphery in DR I think that opens up the treatment pathology and how we can treat these patients more and more better. So I'd like to acknowledge Dr. Rajeshri Salvi, one of our fellow, for helping me. And thank you very much once again for this wonderful opportunity.
Thank you, sir. Thank you for giving information on wide field fundus photography in managing diabetic retinopathy. By giving targeted laser, we can avoid visual loss, especially in night driving mode and all. So thank you, sir. It was very much informative.
But sir, only problem is the cost of the machine, sir, because it's a very high cost. So many people can't afford it.
Correct. Definitely. The cost is, that's why I had put it in the limitation. The cost is definitely a factor.
Yeah,
but
that is one of the.
But I think others can give a view. I'll take just 10 seconds. But I personally feeling I have not found it very useful, especially the targeted laser in the recalcitrant. Although most of these papers have actually proven it, most of these are Western studies. I have not done large studies like them, but in my 5 to 10 cases, I have not seen a dramatic response by doing a targeted laser in these. The others can definitely share their views if I'm wrong. In their patients, how they have worked out.
Actually, we don't have any working experience with this one. If anybody.
So probably it will help us in non-dilating pupils, sir. Maybe where you cannot do FFA. Aptos, does it help, sir, in non-dilating pupil?
Yeah, definitely. In non-dilating pupil, I think that becomes one of the very good indication to do the wide field photography as well as wide field angiography.
Now, if I can add, we have been using the wide field, ultra wide field of Optos, and I can say the best part of it is that you can detect neovascularization very easily just on a fundus photograph, and that's amazing. Actually, because we find it always, people don't spend so much of time on clinical examination, but on the Optos, you don't tend to miss any of them because it's so much magnified, you can pick up anything.
So the only concern mine was in non-perfusion area, hitting the laser, how much it's really going to help in decreasing the DME or decreasing the injection burden load to the patients. Really, to be very frank, I have not come across very well. Others can definitely.
In DME, they did a study on targeted laser and it was found to be of no use. So I don't think now people are doing. There is a trial which was done for that and it did not show any benefit.
No, I agree. That way, not a single patient of PRP should have macular edema.
That's
I think when it was launched, we also were very aggressive. We did a lot of patients, but somehow it does not really work.
Yeah, I agree.
Does it have any role in preventing visual loss in the peripheral vision? Rather than starting from arcade to equator, if you can do laser from equator to big, because hypoxic to anaxic, doing laser from equator to ora, because I read few articles, we don't have any working experience on this one.
See, targeted laser could be useful in very selected cases, where the patient is more likely to follow up with you and the patient has associated macular edema. So in that case, you are giving anti-VEGF also, and to be doubly sure, you can do a targeted PRP so that we really don't destroy the normal retina. And in that case, it could be a good mix combining both.
Yeah, and especially when the patient is not affordable of too much of these anti-VEGFs, I think these are the only choice left for us to do it.
Thank you, sir. Over to Dr. Ravi.
Thank you, sir. Good evening, one and all. Now, the next topic is the OCT biomarkers in diabetic retinopathy by Dr. Hemant Murthy, sir. Sir needs no introduction. He is working as a medical director and co-founder of the prestigious Retina Institute of Karnataka. So he has done his undergraduation from the prestigious Bangalore Medical College in the year 1985. Then he moved to do his residency in ophthalmology at the prestigious RP Center, Alumni Institute of Medical Sciences in the year 1989. And he also has done his senior residency in the specialty of retina in the same institution. And he has got more than 3 decades of experience in the practice of retina. So both at Retina Institute of Karnataka and also is working as a consultant at Satsai General Hospital, Bangalore. To his credit, there are more than 20 publications and has presented more than 300 presentations in both national and international conferences. And he has written 2 chapters in textbook of vitreoretinal diseases. To his credit, there are more awards like APA award in the specialty in the subject of anatomy. Then he has received Bodhras Abrawal Gold Medal for the best outgoing student in ophthalmology at AIMS. He has got a Red Buckler Award for best surgical video in the American Society of Retina Specialist Conference in the year 2014 and 2017. So over to you, sir.
Thank you. Thank you for the kind introduction. First of all, let me thank and congratulate the staff of Minto, Dr. Sujata, Dr. Kalpana, Dr. Hemlata on their 125th anniversary. And I'm very happy that I'm a part of this celebration. Thank you very much. So I'll be speaking to you on OCT biomarkers in DME. Sorry. So what is the importance of these biomarkers? Could be anything. So if you look at it, there are biomarkers in OCT, biomarkers in fluorescein angiography, in OCTA, in any of these, you could use biomarkers, which would actually help you understand the disease, try to diagnose it at an early stage, determine the severity and what type of treatment you would like to initiate. It would also help in predicting outcomes and tailor your therapy. And in the clinical trials, probably it will help us in understanding the disease better. So there are various studies that are being done on these biomarkers, especially in OCT. To name of them, there are about 15 of them. I'll go through them one by one. The first one is the disorganization of the retinal inner layers, or DRIL as we call it. It's primarily the definition of the ganglion cell layer and the inner plexiform layer complex, and the inner nuclear layer and the outer plexiform layer. We look at these and we basically look at the central 1 mm. And if there is more than 50% disorganization, we know that it's associated with worse visual prognosis. So here is a patient who has a 65-year-old male and had a vision of 6/60. You can see that the DRIL is more than 50%. So even after the resolution of the edema following the treatment, patient continued to have the same vision of 6/60. So here's another patient who has DRIL, as you could see in the lower panel, and post-injection, the edema continues to be there. There is still disorganization. Vision after treatment continues to be lower at around 6/18. So DRIL would be one of the biomarkers which would tell you what to expect post-treatment. Then coming to the hyperreflective retinal foci, primarily they are subclinical lipoproteins after the breakdown of the inner blood-retina barrier. It indicates some inflammatory process that is going on, and they are frequently associated with subfoveal hard exudates, and also a lot of times is associated with subretinal serous detachment. So the size and number of HRF may decrease after treatment. If they are more in number, then it would indicate that after steroid treatment, there could be an early recurrence. There have been some studies which said that corticosteroids do better. However, we do see a similar response with the anti-VEGF. Just to show you one patient who had got large number of HRFs. Pre-treatment, vision was 6/18. Post-treatment, we can see that the resolution of edema occurred, though the vision continued to be 6/18. We can see that it does respond to anti-VEGF. So strictly does not indicate that it is not going to be responsive. Probably the best is that after steroid, you have to understand that there would be an early recurrence post-injection. This is a patient with IVTA who had early recurrence following injection because of the presence of HRF. Coming to the pearl necklace sign, this is a precursor of hard exudates in the majority of cases. If it is seen subfoveally, you could expect a drop in visual acuity because of these subfoveal hard exudates. You can see that in this panel, you can see the pearl necklace sign, and post-treatment, you can see hard exudates at the fovea. So commonly, we tend to see these hard exudates coming up to the fovea whenever there is a pearl necklace. Even in patient here, you can see that there is a pearl necklace sign. Vision was 6/18. After Eylea, the edema reduced, but then you can see that the hard exudate is just extrafoveal in this situation. So one should be aware that it would probably indicate some hard exudates coming near the fovea. They could be hyperreflective choroidal foci, which actually would indicate that they have migrated with disruption of the ELM and the ellipsoid zone. It's a poor prognostic marker in terms of visual acuity, and they're more frequently seen in eyes with PDR than with NPDR. Coming to intraretinal cystoid spaces, this is another biomarker which has been classified into small, large, or giant, which is greater than 200 microns. Basically, it occurs due to the elevated VEGF level. There is a breakdown of the inner blood-retina barrier, increasing vascular permeability, and thus causing extracellular fluid accumulation and cyst formation. Now, because of the large cyst, it actually causes stretches and causes photoreceptor damage. So here is a patient who has a center involving DME, vision of 618. There are large cysts in the outer nuclear layer, which results in stretching of the photoreceptors and thus causes damage and poor visual recovery. So even after you treat and resolution of edema, the visual recovery tends to be poor. This is another patient who had got a large cyst, and following treatment, the cyst persists and there is some damage. Vision does not improve beyond 612 because of some photoreceptor damage. The bridging retinal processes have been studied. These actually suggest improved visual acuity after treatment because they are considered to be residual neural elements. So there is a transmission of the visual impulses. So they are preserved Müller cells and bipolar cells. Hence, after treatment, you could expect some improvement in vision. So this is a patient who had presented with this bridging retinal processes, and post-injection vision with one injection has improved to 624, and patient is continuing on treatment. Coming to the retinal fluid index, it estimates the proportion of intraretinal fluid as against the total retinal volume. That is, it's primarily calculated as 100 into intraretinal fluid volume by the total volume minus the SRF. So primarily looking at totally into the retinal fluid levels. This is a patient who had predominantly retinal fluid and pre-injection of 636 following an anti-VEGF. Vision improved to 618. The OCT looks virtually normal, but it has been negatively correlated with vision, whether there has been some damage that occurs with the presence of the higher retinal fluid index is to be studied. So another patient who showed a similar response. Coming to the subfoveal choroidal thickness, greater baseline choroidal thickness means that there is a better anatomical and functional response to anti-VEGF, because that indicates that there is an intact choriocapillaris. So there is less ischemia to the outer retina. So if there is a good amount of choroidal thickness, would mean that you would get a good response to anti-VEGF. The length of the photoreceptor outer segment also correlates with the better visual acuity. The longer it is, would mean that patient would have better visual outcome following therapy. The subfoveal neurosensory detachment is seen in about 15 to 30% patients. It has been studied in the Restore, Rise and Ride, and they say that it has a protective role, and it also ensures a good anatomical and functional gain following treatment. Primarily, it also indicates that there is some inflammatory component to it. A lot of it, if there is an excess amount of subretinal fluid, one should also look at the systemic factors, which could influence occurrence of a greater amount of subretinal fluid. The integrity of the ELM and EZ have been associated with vision very, if the ELM and EZ is ellipsoid zone is fairly intact, the visual outcome tends to be better. If the disruption is more, then you would expect a poorer outcome. This has been studied from long, and here you can see that this pre-injection, you can see that the ELM and the ellipsoid zone is all disrupted, and post-injection vision improves only to 624. You can see that the disruption is seen or very evident in that upper panel. In this patient, a patient presented with pre-injection vision of counting fingers following Eylea. Here, the ELM and EZ is not so much disrupted. So post-injection vision improved to 618. You can see that the ELM and the ellipsoid zone is fairly okay. The disruption is very minimal. So this would actually tell us a little more on what could expect. Here you can see that the outer retinal layers are disrupted, and you can see after treatment also the disruption is present. So visual improvement is only up to 624. So you could predict what you would expect in a patient with this. Vitreoretinal interface abnormalities, you would all know that has an influence on the response to treatment, because they tend to be more resistant to treatment and would require some surgical intervention. This is another patient of an epiretinal membrane. So when they are present, you would have to tell the patient about the response to treatment and the need for surgical intervention. Central subfield thickness has been studied in various studies. I think this is one of the commonest biomarker that is looked into in addition to the vision in rest to look at the efficacy of any treatment modality. So we always look at the central retinal thickness and predict the outcomes of vision. Here is a patient who had a great central retinal thickness was more, and following anti-VEGF, you can see that vision is improved with reduction of the central subfield thickness. So this is a very common biomarker that is used in most of the studies. Now, coming to hard exudates, we know that they are a lot of times associated with the patients who have high triglyceride level and lipid alterations. Steroids are supposed to be more effective in this condition, though it does not preclude the use of anti-VEGF. Here is a patient who had large amount of hard exudates, a version of 660. After an anti-VEGF, you can see that the reduction of edema occurs, but you would see that the subfoveal migration of hard exudates. So patient visual outcome tends to be poor, though you would get a response with either of them. Because of the presence of subfoveal hard exudate, the post-injection vision tends to be about 660 in this patient. So we know that whenever you see hard exudates near the fovea, the outcome tends to be poor. So in conclusion, we could have some biomarkers which have a meaning currently. I know that it is a study which is in evolution. You would probably have much better biomarkers which could tell you what type of treatment would work in which patient. But some of the biomarkers which have some role is the presence of drill, large retinal cystoid spaces, the ELM and the ellipsoid zone integrity, vitreoretinal surface abnormalities, central subfield thickness, and the presence of hard exudates. So these would be some of the biomarkers that you look into, though I know that most of us look into the central subfield thickness, presence of hard exudates, the ELM and EZ. So some of these we already do it, but I think more biomarkers would be there in the future. So just don't look at the thickness of the retina. I think you need a greater look into the morphology and understand these biomarkers, which could help you in your management of your patients. Thank you.
Thank you, sir, for a wonderful presentation. Sir, I have a question, sir. Regarding the precipitate hard exudates in the subfovea. So what is your the plan of management?
No, I treat them. I know that the vision outcome tends to be poor, but that does not prevent you from treating. Whatever be that, they slowly absorb. They do disappear, but they would leave behind some photoreceptor damage. So you would expect a poor outcome. You tell the patient that this is there, so you would have a poorer outcome. But treatment, you definitely continue with the treatment.
The choice of injection in those patients.
Pardon?
Your choice of injection in those patients.
So both, if I look into it, I would, if the patient is phakic, I continue with anti-VEGF. If the patient is pseudophakic, I do with steroid. And I also look into their systemic factors. And if there is something that is deranged, I ask them to get that also under control. But I don't think there is anything that has proven that by one would be more superior to the other. So I think either of them would work equally well.
So, but according to you, they will disappear over time if you treat and
they would disappear, but leave behind atrophy. Na? There would be some amount of atrophy which would occur because of hard exudates being there. So you would come across later on. I think you would see all of them going off. So,
okay.
But it would mean that the poor vision, that would be the only problem with them.
Yes, sir. Yes, sir. Sir, what is I like to ask the panelists, sir, when they decide for surgery and based on OCT. So for a macular edema, I'm not talking about a VMT or a dot posterior highlight. It's just simple macular edema, which is not responding to treatment. So what is
We have a talk on that.
Yeah, I think
Okay,
there would
sir.
be a talk on it. So I think
Dr.
we'll look at
Dr.
surgical
Naresh sir
indications
himself
of
is
it.
talking on that, I think.
Talking on that. Okay.
Yeah, we have a talk on surgical indications for DME.
DME. Okay. Thank you. Thank you, sir.
Sir, we have a couple of cases where the SRF was there and we just treated the hypertension which was associated with the patient, and the SRF had completely disappeared. So
Correct.
that is management of hypertension or associated conditions is very important in such cases.
Correct. So as I mentioned, whenever there is subretinal fluid, there is a lot of systemic association. So always look for systemic factors. So, primarily there could also be that if you see a patient of diabetes who has predominant subretinal fluid, very minimal retinal edema, also look for some blood dyscrasias. We had a patient who had multiple myeloma who presented, so looked like DME, but it turned out to be multiple myeloma. So systemic factors are very important in the presence of a significant amount of subretinal fluid. I mean, that is
Thank you, sir.
neurosensory detachment.
Any questions?
Yes,
Thank you, sir.
Running late, so please continue.
Thank you, sir. Next speaker is Dr. Timlesh Ambi. Sir will be speaking on the artificial intelligence in diabetic retinopathy screening. So, sir is presently working as a consultant in Vitreoretina department at Narayan Nethralaya Health City at Bomsandra. Sir is graduate from Bangalore Medical College and then later moved to All India Institute of Medical Sciences for his post-graduation, and he is did his senior residency in the Department of Retina. He has also cleared an FACO exam from All India Ophthalmic Society. Sir, it's interesting to know that sir is doing a PhD on correlation of molecular and imaging biomarkers in ARMD at University of Maastricht, Netherlands. To his credit, there are various publications and presentations in various conferences, and he has written various chapters in the specialty of retina. So over to you, sir.
Thanks, Ravi. I hope I am audible. Thanks for a nice and warm welcome. I think I should thank Dr. Sujata, Dr. Kalpana, and Dr. Hemlata for giving me this opportunity. And it feels a little nostalgic to come back to Minto, where it all started as an MBBS student. My first ophthalmic posting was at Minto. So thank you for this opportunity. So I'll be speaking on how AI would be useful in managing this particular disease in diabetes. Some of my slides are not moving.
Thiru, click on that slide and then move the arrows. Yeah.
Yes, sir. Yes, sir. We are seeing, sir.
Thank you, Dr. Srinivas. So financial disclosures, I think I should be giving, because I was a consultant. I worked with this group of called as SICTUPL, which consists of ex-IITians who were building an artificial intelligence group. So I was the subject matter expert. I had worked on this for 6 years. So I'll share a few experiences regarding this. So we all come across these terms called as artificial intelligence, machine learning, and deep learning. So it's been there since the year 1950. Alan Turing is known as the father of artificial intelligence, who actually sowed the seeds during the World War. Actually, it was Alan Turing's work which kind of won the war during the Hitler time. So what is artificial intelligence? It's just a computer, which is able to kind of create an intelligent machine that can work and react like humans. So it has more subgroups, which is machine learning. So when we say artificial intelligence, the common artificial intelligence that we use is Google Assistant or Siri in our hands, where we tend to ask the phone something and it will come up with it. Machine learning is another branch where it not only does what you say, but it also improves and gives you suggestions. So machine learning is the machine took your suggestion and it started learning and made some observation. Now there is another branch called as deep learning. So what deep learning does is it tends, gather information, gets trained, it finds out its own mistake and tends to become more and more better as you expose it to more and more data. So what we are using in analysis of these retinal images is these two, the artificial intelligence, machine learning, and deep learning protocols. So why we chose DR is because India is the diabetic capital. I think all the previous speakers have emphasized about it. So screening is a juggernaut in DR. It's the primary crux where once you solve the screening problem, then you can probably treat them early and probably give them better results. We all know that India is on the top list where it is causing problems. Why I put up this slide is that majority of the times you see that the patient has just been, knows that he has been diagnosed with diabetes, and he comes to your clinic and you see that it's at this stage. The patient already has PDR. We all know that diabetes is a silent disease. If you sometimes patients who have been diagnosed with diabetes and this is the stage, because it's a silent disease and he never knew it, right? So screening becomes a very important protocol, and I think it should start with the level of the fundus should be looked at the level where the patient is visiting the endocrinologist itself. So keeping these in mind, we kind of put together a team with these IITians, and we started doing what is called as machine learning protocols. So these are some of the outcomes of that particular work, where we train the machine using multiple images, and this is the end product, where if I can drag drop this image onto this particular software, it will tell me where and all it is abnormal. And with an accuracy, first and foremost, it will tell you whether the image is gradable. Then it will give you a probability of whether it is a NPDR or a PDR, or whether it is normal. So what we did was we wanted to compare how accurate this machine was. So between the period of 2017 February and September of 2017, we took about 4,500 images, and we showed it both to the machine and also to a group of fellowship trained vitreoretinal specialists, and we kind of put together results and see whether AI can it really do it or not. So we use this particular classification to make the diagnosis, and we also gave it a scoring system for what is called as a referable DR. So we all know that if it's mild NPDR, there is no need for referral. You can call the patient safely after 1 year. So when we say referable DR, so we wanted to make a diagnosis of moderate NPDR, or any patient who had moderate NPDR with macular edema. If it was not there, then we would call it as non-referable DR. So based on this methodology, we trained the AI, and the same thing was also given. So how do we train the AI is you have this interface protocol where a particular specialist or the subject matter expert is going to sit and analyze a very tight annotation regarding where is the disc, where is the vessel. And if there is a hemorrhage, we tightly annotate that, and then the batches are put together for the learning protocol. So once that is done, the machine learns it, and then once you put an image, it will give you a probability score whether a particular image, does it have diabetes or not. So what we found out was that when we compared the AI with fellowship trained doctors, what we found was that with referable DR, the precision was pretty tight. It was about 0.97 when we give both the specialist and also the AR a very good gradable image. But when you give a non-gradable image, it was right only in about 65% of the times. For the retinopathy model, once where we saw that once they were gradable, the precision was almost 94%, with a greater sensitivity of 91%, and specificity and recall being pretty good. And it was able to do it in about 1,800 images. And for non-referable DR, it was able to do that in about 1,300 images. Now, if you look at the subcategory analysis, the precision was pretty good. But the overall sensitivity, when it was mild NPDR, you see the score is only 41%, which means that it was calling mild NPDR as normal. Sometimes it would call normal as mild NPDR, but nonetheless, these are non-referable conditions, so it really did not make much of a difference. But when it came to identifying moderate or severe NPDR or PDR, the scores were anywhere between 85 to 99%, which means that AI can definitely do the work. So these are ROC curves which were plotted based on that particular data. And what we also found out was that within our primary work group, so we also had, sometimes there was a difference in opinion where someone would have diagnosed it as moderate, someone would have diagnosed it as severe. So these were resolved by what is called as a co-consultant meeting, where you make all of them sit together and then you put the image, and all of them would give the score then and there, and that's how you would solve this problem, so that the machine does not get more and more kind of confused. But once the ground truth was established, where it was a combined analysis, and once that particular data was used to train the AI would kind of come back with the level that it can diagnose with the level of confidence as a fellowship trained doctor. Now the limitation is that the training and the data that we were able to generate was based on a retrospective tertiary care data, and what we should have done was we should have taken this forwards to the clinics, but unfortunately we don't run too many DR screening camps, so we were not able to provide that kind of facility to the company that we were working. However, they took this machine to the government of Wales, and the University of Wales is currently deployed this machine for over a period of 1 year, and the results I think they would publish in some time. So in conclusion, AR kind of has a very good effectivity level. Now, what we did next was we also wanted to see if the AI can read the OCT and give us predictability with reference to so-called biomarkers and patterns of how edema would disappear based on the longitudinal study. So we kind of aborted this project at this level, where we developed it to a level that we trained the AI to kind of identify location maps and where it is abnormal, how it is abnormal, and what biomarker is abnormal. But we were not able to take it to the next level where we could really develop an algorithm, because it required large amount of longitudinal data. However, an Israeli group under probably Dr. Annette Levinstein is currently taken up that project further, and they are coming up with newer protocols where the machine itself can tell you the resolution protocol, and it's at research level. It might take some time to come into the real clinical picture. So you can see that these are a few images where the AI can actually identify where the pathology is. It's not just DME, it can also identify ERMs, it also can identify abnormalities in the RP. With good recall scores anywhere between 85 to kind of 95, depending upon whether it is a hard exudate or a fluid or traction or the membrane, these kind of things. So thank you for this opportunity. I think I have shed a little light on how AI can be useful in practice. This is kind of something which can be adapted to future protocols. This is something which is at the level of kind of development. But the more we adapt to it, the better AI would become. And contrary to the belief that AI would take your job, if AI can be deployed at various levels for screening, you would probably end up with more amount of work to do and more concentrated work on areas where it is abnormal and which really requires your time and attention. Thank you so much.
Thank you, Dr. Tirumale sir, for a wonderful presentation. Definitely, it will help us in screening and early referral. Okay, so I think it's better if all diabetic clinics have this kind of a mission, so that they can at least refer the cases for early treatment, so that we can prevent the blindness. Thank you, sir. Any questions from the? So now, next I request Dr. Shilpa and Dr. Kavita to moderate the next session.
Good evening, all. I welcome you all to the next session. The next speaker is Dr. Sri Bhargav Natesh. He is going to talk to us about various modalities of management of DME, including micropulse laser, intravitreal steroids, and anti-VEGF injections. Sir needs no introduction. He is director at Netra Eye Hospital, and he is CMO at Eye Drishti Hospitals. He is a UG from CMC Vellore, and he did his post-graduation from our own Minto. He did his Vitreoretina Fellowship from Shankar Netralaya. He did Ocular Oncology Fellowship from New York Eye and Ear Infirmary. Over to you, sir.
Yeah, thank you. Thank you for kind introduction, and thanks to Minto Group for giving this opportunity. So my topic is about micropulse laser and intravitreal injections. Vast topic, and I will try to condense to the best possible time management. So the management of options for diabetic macular edema, as we all know, would involve anti-VEGF agents, steroid injections, biosimilars for the anti-VEGF agents, including the next entry would be a biosimilar to the aflibercept, then laser photocoagulation, and in that we have micropulse options, and then we have surgical options. So this is the algorithm that we can think of. Of course, when the patient enters the hospital, we would like to do all this before we start the patient treatment with ophthalmic modalities, evaluation of HbA1c, diabetic complications, assessing comorbidities. That will help us to basically decide the treatment management also. A complete eye evaluation, by microscopy, visual acuity, OCT, fundus fluorescein angiography, Octa, have their own role in assessing the patient and positioning the patient in the level of severity so that we can decide. So once we decide patient has a macular edema, then we kind of call it as a mild central involving or a severe one, which may be non-central involving also. If the macular edema is severe enough and if there is no central involvement, we do the laser treatment. And if there is central involvement also, and if it is a mild one, we have options like micropulse laser. So laser has its own benefits and risks. Risk is known that it doesn't really improve the vision, and there's a possibility of an extension of laser scar into the fovea if it is done too close to the FAZ. There are benefits, of course. We've been using lasers for ages now, but it is still not comparable to other newer therapies that we have with steroids and intravitreal injections. I do micropulse. It's a novel way of treating even the central involving macular edema. Of course, the continuous wave has been time tested and effective. In conventional laser, we do focal to leak and macular grid to the area of the leak. But there is a thermal damage to the macula. It limits the number of times one can do the laser. Of course, the effectiveness is not to be questioned. These are all the settings that we use. We have to understand that it's the RP and the choroid that absorbs the energy, and then there is a heat that is getting generated, which photocoagulates the protein, and the retina is the bystander. In micropulse, what happens is the continuous wave, which can be depicted like this, which induces a temperature rise of this sort, can be fractionated into a chain of or a train of pulses where there is an on time, where there is a small thermal dissipation and increase in the temperature, where there is, because of the peripheral dissipation, there is a during the off time there is a cooling off period. So basically it's akin to heating the tissue and then allowing it to cool off enough so that the temperature never reaches a level where the tissue is or the protein is denatured or coagulated. So thereby we have a benefit of the thermal laser, but with no side effect of the tissue getting burnt. So if you can depict this as a visible conventional laser continuous wave burn, where the center portion is actually photocoagulated. So it is the surviving cells which is in the periphery that actually become active. And they are the ones which produce biological factors which are antigenic in nature. So if you can kind of change the settings to such an extent that the entire tissue under the laser burn is stimulated and survives the heat shock, then it produces biological factors. And because we all know that during the micropulse, it's like painting the entire macula with laser. The entire macula acts like a angiogenic factory to say, and there is a significant amount of macular edema reduction that can happen. So a micropulse again is was to be a low intensity and a low density. Now we have understood that the high density laser burns are the ones which actually work. So we are kind of moving from a high intensity, low density laser to a low intensity but a very high density burn. So these are my settings. I usually do a 200 micron spot size, 200 milliseconds, 400 milliwatts during the first setting at 5% duty cycle. This 5% is very important. Anything more can actually burn the retina. And combined with anti-VEGF injections, of course, it's the other way actually. That's the anti-VEGF injections which are always combined with micropulse. As the standard alone, it has very limited role. So we are moving away from the conventional high intensity, low density lasers to low intensity, high density lasers. This is how the micropulse work. Few case examples which I have treated with only micropulse. Of course, it's rare. We always combine it with other modalities, anti-VEGF steroids. But it does work, and it needs repeated lasers. We do see there can be significant changes in some select patients. It has the advantage of continuous wave laser without tissue destruction. That's the whole summary that we need to be thinking about. So coming to the more severe forms of macular edema, where we assume that the micropulse alone is not sufficient, then we look at the core morbidities with no cardiovascular disease. Probably anti-VEGFs are the first one to be considered. So when we say no cardiovascular disease, basically we mean that the recent history of cardiovascular events including a TIA, stroke, heart disease, peripheral vascular disease, especially what happens within the previous 6 months is something which has to be taken into account. A previous history of a bypass or a angioplasty which happened 10 years ago and the patient being good enough, I don't think is a contraindication for anti-VEGF, and this is what most of us are practicing now. So if the first line anti-VEGF doesn't work, then we will consider other modalities. So coming to the anti-VEGF agents that we are all familiar with, we have ranibizumab, aflibercept, bevacizumab. I will not go into the details, and protocol T was one of the first in the literature which did head-to-head comparison between these three molecules. We have a new molecule now, brolucizumab. Of course, diabetic macular edema is at this present off-label use. So this literature told us how to use our anti-VEGF very effectively, and we've been using it since about 10 to 15 years to the benefit of our patients. Coming to the injectable steroids, we have off-label triamcinolone acetonide, and then we have the DEX implant. Whenever DEX implant is being considered, a cataract progression is something that we have to keep in mind. A patient with a phakic eye and with accommodation, we have to be little watchful about. And an intraocular pressure increase is something that we need to be watching out for. Of course, it has multiple benefits. One of the major benefits compared to anti-VEGF agents is it's long duration. Close to about 3 to 4 months of injection interval is what we achieve. And especially it can be combined with anti-VEGF also to get a wow effect and also a sustained decrease in the macular edema. So when the patient has cardiovascular disease, it actually becomes the first line of treatment, especially if the patient happens to be pseudophakic and if there is no risk of anti-VEGF glaucoma. Then the second line will be the anti-VEGF and lasers. Sometimes by doing laser, we also can buy adequate time of 3 months to 4 months where we can wait for the critical period to get over and then subsequently inject the patient. That also works. Illumin is something which is not available in India and has not been proven to be extremely effective also. And it has its own side effects of, which are very well known for the more severe forms of steroid-induced effects. In vitrectomized eye, the choices of injections will come down significantly. Anti-VEGFs, because of the increased washout, will be a less favorable option. Triamcinolone acetate, the IVTA injection, especially given in a vitrectomized eye, can cause a lot of problems because of the vehicle, the fundus visibility will come down. We can have these pseudo-hypopions and may not be the great choice. But Azuredex happens to be a good choice, and probably among the choices that we have in vitrectomized eye, Azuredex implant is something that we can consider because post-vitrectomy also, we know that the macular edemas can persist and be troublesome. The last indication would be the tractional macular edemas. In this, we have various entities like we have taut posterior hyaloid membrane, and they have vitreomacular traction. Of course, macular involving tractional retinal detachment and combined retinal detachments are the indications where we do pars-plana vitrectomy. Sometimes we also do ILM peeling and consider to add steroids or anti-VEGF injections at the end. So that would be it, and I'll be happy to take questions. Thank you very much.
Thank you, sir. We have one question. Whether you do micropulse laser even with SRF? In patients with SRF, do you do micropulse laser?
As I said, micropulse alone probably is not the correct thing to do. Because now when we have anti-VEGFs which are known to work well, not giving this option to the patient is unethical. So that's what I would say. But I don't think SRF is a contraindication to do micropulse. I do micropulse even with SRF.
So Bhargav sir very rightly said. But what is your cutoff point in the central macular thickness or the central CFT? Would you like to use in for doing this micropulse? Because I have tried 400, even in 350. Sometimes it doesn't work at all. So I think there are many other multifactorial cause of the disease as well for this. So what's your recommendation? What's your cutoff point for starting or initiating the micropulse lasers?
If we are talking about treating the patient with micropulse alone, micropulse was as good as lasers. Because the lasers did not work for macular edema is the reason why we have anti-VEGFs today. So micropulse alone will not be a great tool. Basically, I will use it for very milder forms. For example, 6-9 edema with a small cyst at the fovea. I'll definitely do micropulse first for those patients with topical NSAIDs and try to control the glycemia and blood pressure during that particular time. And but as of now in my practice, I always do with anti-VEGF, and with the anti-VEGF after it comes down to less than 350, 300 kind of edema is when I do start doing micropulse. Actually, one micropulse session probably will not be sufficient, and it may need to be repeated multiple times.
I had
asked the other panelists.
Srinivas, before saying that micropulse has not worked, how long did you wait?
I tried even with the 5% and 10% of the duty cycle also. I waited for nearly 3 months. So in spite of that, since I did not have the response for that, so I was a little bit confused now. And I think I agree with Bhargav sir. With large cystoid spaces, with the BRPs, bridging retinal process, the remaining and all those things, I don't think really micropulse actually has a role to play. And basically you need to drive it with anti-VEGF, and once it comes down, then probably doing it might decrease the number of injections what we are planning to give in for the patients for the next.
Yeah, I would probably recommend only 5% duty cycle. At 10 to 15%, actually you can start having the retinal burns, and definitely nothing beyond the 5%. I've had retinal burns at 10%. So definitely 10% and 15% is not to be considered. That is one thing. And especially with phakic patients, if you see some amount of nuclear sclerosis, it's always better to go up by about 10 to 15%. So instead of 400 milliwatts, you can go up to 460. And there are people now who are suggesting that you entire macula, you paint it once and then go back, you paint it again in the same setting. But I do use about 600 to 700 spots.
Sir, I agree with your point, but how to titrate this? Because these are invisible burns, and you have the nuclear sclerosis where you say that you are going to 10 to 15%. How can we actually know the titration? And because grading is very variable in these nuclear sclerosis.
There is no titration with micropulse. That's a hard fact that we have to consider. It is very, very similar to the TTT that we were doing for CNVMs, back 15 years ago.
So since there is no titration, then in what cases, how we know that we have to increase the duty cycle to 10 to 15% was my question.
Yeah, there are ways actually to pick up. You can have a physical burn at 10%, then half the energy. There are so many normograms that are given by Samur and different scientists actually.
Does the thickness of the macular edema influence your duty cycle?
Oh, definitely yes. I mean, for a thicker macular edema, it's not going to work. So better not to try for edemas which are 700, 800. For them, better to get the macular edema down and then start doing micropulse. But for the smaller macular edemas which are less than 300 or 300 to 350 kind of edemas, definitely it's worth doing macular edema. I use it for all indications like CSR and macular edemas, RVOs, and I've had. As Tirumalesh was mentioning, not waiting for just 1 or 2 months actually is definitely not sufficient. And even with the conventional laser, we never had this kind of a effect, within 1 or 2 months actually. We would do laser and call the patient after 3 to 4 months when we were treating diabetic macular edema with lasers alone. I'm talking 15 years ago. So expecting micropulse to work like conventional treatment also is probably not correct, but it does work. But as I said, 2 to 3 months after, I do call the patient if suppose the patient doesn't agree for anti-VEGF, which happens even now with some patients actually. They've had injections, they're frustrated, they don't want to try anything more. And for those patients, I call them after 2 months and then increase the energy by about 15%. If I've done the first session with 400, I go up to 460 or 417, again redo the laser, and then subsequently I call them every month. Those are the patients who actually start showing some benefit. It's definitely not as dramatic as anti-VEGFs. Not to be, I don't think that's the message to be taken at all. It should be combined with anti-VEGFs. I feel that the number of injections come down significantly if I have a small data, especially with RVO. When I combined with micropulse, the number of injections came down by 2 injections in the year, which means that, instead of about 8 injections in the non-micropulsed eye, it came down to about 6 injections in the micropulsed eye.
Okay.
Thank you so much, sir. It was a nice discussion on the management of DME. Over to you, Dr. Shilpa.
Good evening, everybody. The next topic is by Dr. Naresh Kumar Yadav on surgical indication in diabetic macular edema. Dr. Naresh Kumar Yadav, sir, is a senior consultant at Narayan Nethralaya, Bangalore. He did his retina fellowship from Shankar Nethralaya, Chennai in 1998 and FRCS in 2006. He has over 70 publications in various national and international journals. He has been the PI for many multicentric clinical trials. He has special interest in vitromacular interface disorders and TRD surgeries. Over to you, sir.
Yeah, thanks for the kind invitation. At the outset, I would like to thank Dr. Sujata, Dr. Kalpana, and the entire Minto team for having me here. I'll start sharing my screen. I hope I'm audible and the slides are visible.
Yes, sir. Yes, sir. You're audible.
Okay. So my topic is surgical indications in DME. So we know that repeated anti-VEGF injections are the treatment of choice in managing DME cases. And even after repeated injection, a large proportion of patients do not respond adequately. And repeated intravitreal injections come at a great economical cost. It's a great psychological and physical burden to the patient. And basically this treatment burden is the main cause for suboptimal visual improvement. So we know that DME pathogenesis is complex and multifactorial, and vitreous definitely plays a part in DME. Nasrallah in 1988 found that the posterior hyaloid was attached more frequently in patients with DME. And this traction on the macula, he attributed that it is playing a part in the DME. Hikichi et al. Followed a cohort of patients, and he found that 55% of the cases had resolution of the DME upon PVD, and only 25% of the cases without PVD had a DME resolution. So I think it's time again to revisit pars plana vitrectomy. It could be a cost-effective alternative to chronic anti-VEGF therapy, and with the improved instrumentation, better viewing system, the complications of PPV has come down. So I think we should be more open to this therapy. So this is one of my patients. You can see there is a vitreomacular traction, there's a gross cystoid macular edema, and there is a ERM. And the patient's vision was 624. I told the patient that we'll plan for anti-VEGF, and he could need pars plana vitrectomy if there is a suboptimal response. The patient said not very convinced. He said, okay, I will think over it and I'll come back. And after 3 months, the patient came back and I saw that the vision had improved. So this has happened. So there was a PVD induction. So the patient has not taken any anti-VEGF and the edema has totally gone away. And you can see there's a PVD that has happened. So this is a temporal association. Definitely PVD has a role to play in the DME. This is another patient. The other thing is that you should always be aware that with time, vitreomacular interface abnormalities can happen. So this patient had 660 vision. There's a subretinal NSD is there. There is edema, and patient was responding adequately to the anti-VEGFs, and suddenly he developed ERM over a course of 6 months, and then he stopped responding to the anti-VEGFs. So you can see there is a gross ERM, and the multicolor also picks it up very nicely. This is another patient. In the right eye, you can see there is it's a ERM or a thickened hyaloid, and the left eye had a PVD. So both eye, the vision was 636, but the right eye needed 5 injections and the left eye needed just 2 injections. So this also shows that if there is a vitreomacular interface problem, ERM, the diffusion of the drugs is going to be less. The cytokines can get entrapped below the hyaloid. So these patients are not going to respond very well to the anti-VEGF injections. So why there is a altered VMI in diabetics? So hyperglycemia causes abnormal cross-linking of the vitreous collagen fibrils. The BRB breakdown allows cytokines to concentrate in the VMI, and this stimulates the migration of cellular elements with contractile properties onto the posterior hyaloid thickening, and this can cause traction and DME. And ERMs and ILMs also cause traction. It also acts as a diffusion barrier. So how can PPV benefit in DME? It increases the oxygen concentration in the vitreous cavity, and thus it will downregulate the VEGF secretion. The oxygen from the retinal arteries is not able to diffuse widely because of the vitreous viscosity, and the ascorbate present in the vitreous also consumes the oxygen. So if you do PPV, this allows a uniform mixing of the and distribution of the oxygen in the vitreous cavity fluid, and a higher concentration of oxygen causes retinal vasoconstriction, which may decrease the macular thickness. The other could be that it eliminates traction by removing the posterior hyaloid, ERM and ILM, and PPV improves perifoveal capillary blood flow, and this has been correlated with the improvement in visual acuity. And PPV clears the vitreous cavity of the cytokines that are released, and on top of that, it will lead to faster clearance of the newly secreted cytokines. So there's a good background that PPV could be a good option. So this is one study where they looked at the PPV was done in patients with DME and VMT. So 87 eyes with DME and VMT underwent PPV. Almost 90% of the patients showed reduction in the macular thickness, and the visual acuity improved by 10 letters in 38% of the patients. So definitely it is sure that vitrectomy is useful in patients with VMT. This is one of my patients. You can see the fundus photo and the OCT. There's a vitroschisis, vitromacular traction. So such cases, there is no doubt that pars plana vitrectomy is indicated. And this patient did well post-surgery. The vision improved to 618. This is another patient. There's a broad vitromacular traction, cystoid macular edema. The patient did not really do well. Even after 2 anti-VEGF, there was no response. So I took this patient for vitrectomy, and you can see there was a good resolution of the macular edema. So if there is no vitromacular traction also, still the attached posterior hyaloid can cause traction, and it can aggravate the DME. So this was shown by Tachi et al. So he operated 58 eyes, and almost 98% of the cases, the DME resolved after PPV. And similarly, La Hezi et al. Also showed that the DME resolved in all eyes at a mean of 3 months after pars plana vitrectomy. So the other thing is there's a detached posterior hyaloid and ERM is present. So this also group of patients will definitely do well with pars plana vitrectomy. So the glial cells of the ERM themselves express various cytokines, including VEGF. And the ERM acts as a mechanical barrier, which reduces the permeability of anti-VEGFs and steroids. And all eyes with DME show some degree of ERM formation when assessed with electron microscopy and immunohistochemistry, even when no ERM seen on OCT. So this is important. A lot of these patients will have some microscopic ERM, and pars plana vitrectomy with ILM peeling is going to take care of this. And pars plana vitrectomy with ERM peeling is generally an effective treatment in eyes with chronic DME refractory to pharmacotherapy. So this is the same patient that I showed. So received injections and was not doing well. And this patient underwent vitrectomy. So you can see from 636, the vision has improved to 612. The outer retinal layers were very healthy. So the patient had good visual acuity improvement. So this is just a small video just showing. So here I usually stain under air. So I have used brilliant BBG dye to stain the ILM. The ERM can be peeled it is not stained, but with a negative staining, you can peel the ERM also. And a large ILM peeling is advisable from arcade to arcade. And the retinal tissue can be friable and it's ischemic. So if you're not careful, you can cause iatrogenic breaks. And try to pinch the ILM near a vein. So there's a little space there. So pinching could be easier there. And you may have to stain the vitreous multiple times because of the vitroschisis. And the other thing is there, sometimes there could be firm adhesions to the vascular tissue. So you don't have to really peel normally. If there's a firm adhesion, you can leave that area. So you can remove the ILM in patches also. If you leave some ILM behind, that is fine. Sorry. So this other case, there's a detached posterior hyaloid and there is no vitreomacular interface abnormalities also. So a variety of cellular elements and inflammatory cells adhere to the thickened inner surface of the ILM. The ILM itself is very thick in patients with diabetes. And the undersurface, you can get a lot of inflammatory cells that adhere to it. So pars plana vitrectomy with ILM peeling will do well. So Gandorfer et al. So he had 18 eyes had PPV and 55 eyes had PPV plus ILM peeling. So he compared two groups. In one group, only PPV was done, and the other group, PPV plus ILM peeling was done. The both groups showed DME resolution, but greater DME resolution was seen in the ILM peeled eyes. But a meta-analysis found that in patients affected by non-tractional DME, whether you peel ILM or you don't peel, there was not much of a difference. But definitely, if you peel ILM, there's a reduced risk of recurrent TRM and subsequent DME is a possibility. So basically, PPV decreases retinal thickness but does not lead to visual acuity improvement. This all we know. So why this paradox? Because we have a general thinking that if the reduction in thickness is there, the visual acuity should improve. So it does not happen. Why? So according to Harbour et al., he emphasized the importance of prompt surgical treatment because eyes with long-standing DME could develop outer retinal atrophy. So basically what's happening is most of the time we are doing it as a last resort. So by the time a lot of damage has already happened, and at this stage, doing pars plana vitrectomy is not going to be very fruitful. And Michael Veska performed pars plana vitrectomy in treatment-naive DME patients. So all these patients were treatment-naive. And he showed that more than 50% of the patients had an improvement of more than 3 lines, and only 2% lost more than 3 lines. So to conclude, PPV can alleviate DME through multiple mechanisms. DME with VMT, there's a definite benefit from pars plana vitrectomy. And I think that DR should be termed as diabetic vitreoretinopathy, just not retinopathy. And DME with no vitreous traction, as of now, the data is not very robust, but we need to operate early and not as salvage treatment. And to test this hypothesis, larger clinical trials are needed. Then only we'll know the correct answer. Thanks for a patient hearing.
So thank you, sir, for sharing your knowledge on when to approach surgical intervention in diabetic macular edema. There's a question for the speakers, whether they should be patients should be given preoperative steroids before vitrectomy in cases with large macular cysts.
No, as I told earlier, as of now, we are doing pars plana vitrectomy as a salvage treatment. If it's a non-tractional DME, if you see there's a large cystoid edema, large cysts are there, then definitely you can give steroid. The other thing that you could do is that you could do a foveal sparing ILM peel. So you don't have to really peel the ILM across the fovea. So that way you can be sure that you are not de-roofing that cyst.
Any other speakers want to add to this? Panelists?
I think I had done a study which I think I presented in one of the VRSI meetings on. I had done a comparative study between tractional DME and non-tractional DME, and as Naresh was saying, in non-tractional DME, the edema came down, but we did not see any visual benefit. So that's what we did in some set of patients. So I did an inverse peeling. So basically, I did the fovea sparing ILM peel in all these patients to prevent any de-roofing of the cysts. So,
what do you feel that should we be more aggressive and start operating earlier because the complication rates have come down? Earlier we used to be always scared. Now we operate ERM for 6.9, 6.6 vision also. So if we
but that's what. So biggest problem is to give patient expectation of post-op outcome is the challenge in all these patients.
I think people have done past planar vitrectomy for subfoveal exudates also. So they say that those patients also where vitrectomy was done did better as compared to the patients who were just given anti-VEGF. So that also study is there.
Sir, also there are articles saying submacular injection of anti-VEGF during vitrectomy for this diabetic macular edema.
Dr. PB wants to come in. Yes, sir.
Yeah, no, I did more than 25 cases with those intraretinal, subretinal hard exudates once upon a time. But what happened by the time patient reached to that stage, it sounds nice. It's you feel heroic. Exudates come out. So, and I have videos of that also, because post-operative they look very nice. But because see the fact you are exudating in intraretinal space, structural damage has already occurred. So very few of them improved. Only I think the best visual acuity, I got one patient 660, and somewhere they stay between 260 or 360 vision. So after some time, then you give up. So in fact, looking at other way around, there are a few cases, and rather in fact, when I initiated having a significant amount of hard exudates, and the patient, I said nothing can be done, bilateral exudates, 3-meter vision. And then he come back with a vitreous hemorrhage back again, complete PVD. And there's no other way but that 3-meter also gone. So I did vitrectomy. Everything went off well. It took almost 6 to 9 months. By the time everything settled down, that fellow is having a now 618 vision in one eye and 636 other eye. All the exudates are got absorbed. Yes, when you look at OCT, doesn't look very encouraging, but he is maintaining 618. So with all this, having a variable image pictures, so primary vitrectomy for intraretinal hard exudate or subretinal hard exudate, we have stopped now doing.
Can we move on to the next speaker? So next speaker is Professor Dr. B.N. Kalpana. She'll be talking on approach to cataract surgery in diabetic retinopathy. At present, Professor Dr. B.N. Kalpana is the medical superintendent and head of vitreoretina department at RIO MOH. She did her graduation from BMC, FRCS in 2005 from Glasgow, United Kingdom. She has done her vitreoretina fellowship at Shankar Nethralaya in 2008. She has more than 100 paper and poster presentations at national and international conferences.
Thank you, Dr. Shilpa. Am I audible?
Yes, ma'am. Yes,
Yeah.
ma'am. You're audible and we can see the slides. Kindly
Yeah.
go to the slide share.
Yeah, I started seeing my shares.
Yes, ma'am, we can see.
My slides, okay. Today, before I start my presentation, I would like to thank my teacher who is present here today, Dr. Pramod Bende sir, without whom when I went for interview for fellowship at Shankar Nethralaya at the age of 42, he gave me an opportunity to do my fellowship, and that is why today I am amongst you. So I am very grateful to you, sir, and I am really happy you are here. Thank you, sir. And current topic of mine is approach to cataract surgery in diabetic patients. So why cataract surgery is different in diabetic patients? We have all seen that there are visually significant cataract pose unique challenges during surgery in diabetic patients, and even the visual outcome following cataract surgery in diabetes may not be always very good. Hence, we need to pay a little more attention for the pre-treatment of the diabetic retinopathy, and also we have to follow the minimally invasive surgical techniques to get a good vision following cataract surgery. So there are various clinical studies which shows there is incidence of diabetic cataracts or much more. Like Framingham study showed that there was 3 to 4-fold increased prevalence of cataract in patients with diabetes. And not only in type 1 diabetes, even type 2 diabetes, the incidence of cataract is much higher as per Wisconsin study, so almost around 25%. So the type of cataracts also are influenced by the glycemic control, like cortical cataract and posterior subcapsular cataract in diabetes patients. So an uneventful cataract surgery may also still result in worsening of maculopathy in diabetes, and rapid progression of diabetic retinopathy due to poor glycemic control is very well known. It also induces high-risk new vessels and precipitate vitreous hemorrhage and ultimately lead to decrease or loss of vision. So timing of cataract surgery is also important in diabetics, because earlier the surgery, so the better the visual outcome. And whenever the eye is quiet with diabetic retinopathy, the macula is dry, so we better to plan the cataract surgery. If diabetic patients in cataracts associated with non-clearing vitreous hemorrhage or TRD, it's better to combine cataract with posterior segment surgery. So phacoemulsification is the choice of cataract surgeries in diabetic patients. They have said to does not accelerate the progression of maculopathy or the retinopathy, as per the various studies showed by Doller and Shaw and Chain. And this is said to be because of the smaller incision size as well as the reduced inflammation due to the less breakdown of the blood ocular barrier in phacoemulsification. However, we see that visual recovery in uncomplicated phacoemulsification is not just because of the successful surgery, but it is also influenced by the stage of diabetic retinopathy as well as the severity of retinopathy. And the treatment naive PDR before cataract surgery may progress to vitreous hemorrhage as well as TRD following phacoemulsification, thus threatening good visual outcome. So pre-op evaluation, so we all know that it is not much different from that of non-diabetic cataract, but we only have to place more emphasis on the presence and extent of diabetic eye changes in these patients. So we need to establish that the degree of cataract what we see corresponds to the patient's visual acuity and reported visual dysfunction. If the patient reports severe vision problems, but the examination shows mild cataract, we have to carefully analyze the retina for other diabetic changes. So pre-op consideration is very important, and preoperative counseling is very essential in these cataract patients with diabetes, because the visual recovery may not be as in non-diabetic cataract surgery. Patients must have good glycemic control and also rule out ocular or periocular infection. A good IDO evaluation and ancillary evaluation such as fluorescein OCT and B-scan if needed, and if cataract visibility permits. So preoperative use of non-steroidal anti-inflammatory drugs such as diclofenac and nepafenac also has said to reduce the chances of postoperative macular edema in patients with diabetic retinopathy. So B-scan is also useful, especially in media hazy when the cataract is very dense. So it can pick up if there is any media opacities like asteroids, or detect even the vitreous hemorrhage. To assess the vitreoretinal interface, presence of a PVD or vitreoretinal refraction, to rule out the presence of any TRDs or combined RDs, and to assess the status of macula. It can also give us the fairly good view of ONH status, any glaucomatous cupping due to secondary glaucoma. So preoperative management, we need to always address the untreated PDR. So PRP is recommended preoperatively. In case if the lens opacity precludes, you can try PRP with indirect laser ophthalmoscopy. If that is also not possible, it is better to do PRP within a week after cataract surgery. So there are, the aim is to make the cataract surgery less traumatic. So it is better to operate the cataract patients in diabetes by an experienced surgeon. Uncomplicated and quick cataract surgery is preferred. Good wound construction is a must to minimize the infection, and minimizing the phaco time and as well as the energy. Running less fluid through the eye and avoiding contact with the iris are all essential. So we also know that the diabetic eyes have poor pupillary dilatation, particularly with active rubeosis iridis or even vigorous neovascularization is present. So we need to think about pupil stretching because of the risk of hemorrhage in these patients. So the IOL also we need to have a preference for acrylic hydrophobic IOLs. We all know that the PCO is very common in diabetic cataracts because of the increase in phosphorus level. And it is always important, like whenever there is a macular edema, to avoid multifocal IOL, and monofocal IOL in the back placement is very ideal. Silicone IOLs also should be avoided as its affinity to silicone oil is high. And we also have to manage diabetic macular edema, which is 20 to 50% higher, especially even the central involvement DME, before the cataract surgery if possible. So we can treat them as the treatment T protocol. Intravitreal injection of steroids or anti-VEGF can be given. So either aflibercept, bevacizumab, or ranibizumab, and even laser photocoagulation may be added subsequently. So post-operative management. So we have to not only treat for the post-surgery inflammation following cataract surgery, but we have to follow up for the diabetic sequelae and treat them following cataract surgery. As I already said, the PCO is common and persistent post-operative inflammation, so steroids may be needed for a longer time in these patients. So follow-up for visual improvement and management of diabetic retinopathy is very essential, and also refer to VR surgeon in case of PDR and its sequelae. In some cases, intravitreal injection of triamcinolone or anti-VEGF medication is given at the time of or before cataract surgery. So whenever the extensive changes are there, like vitreous hemorrhage or TRD or the cataract surgery can also be combined with pars plana vitrectomy. So you need to approach a VR surgery. So let us see some examples. Like this is a case of a 55-year-old male with complaints of gradually progressive painless dimness of vision in left eye. The patient was both diabetic as well as hypertensive on medication, as well as IHD of 1 year duration, had a GRBS of 209. So this is the cataract, like you see here, it is very mild, so nuclear sclerosis of grade 2, and both eye had a comparatively good vision. Fundus showed only moderate NPDR, and you can see the fovea is not much involved. So it is, but you see this macular edema, so non-foveal, foveal sparing. So here, so good glycemic control is important, and we don't have to hurry for cataract surgery. And DME in left eye can be treated with focal or grid laser. So another patient, he's also a 58-year-old patient who had a moderate NPDR in both eyes with PSME. So OD macularosity was normal. So the left eye had a 410 microns of macular edema. This patient received injection anti-VEGF, and after 1 month, vision improved to 6/9, and the macular edema reduced. However, patient revisited us after 1 year. So the patient had uncontrolled diabetes, and this patient again had a mild or early cataract. Fundus showed moderate NPDR with PSME and both eyes. And you see the society shows in the right eye still macular edema and irregular episodes on the octa. So even in the left eye, there's some amount of macular edema as well as irregular episodes and some areas of capillary non-perfusion as well as some NVE. So in these patients, along with systemic glycemic control, so as the view of fundus is clear and OD, the central macular thickness was much higher than the OS. Intravitreal injection was first given to right eye subsequently, the left eye was also treated. So after as it showed NVE and CMP areas, PRP laser 3 sittings was considered in the left eye. Some of the cases of the PDR, so we had a 50-year-old female who came to our OPD with complaints of sudden painless dimness of vision in left eye. Patient had complaints of floaters, and patient was a long-standing diabetic of 28 years and also had pulmonary coughs for which she had received treatment, and the GRBS was 200. Here you can see that the patient had a vision of 618 improving to 612 in the right eye, whereas only fountain finger vision in the left eye and no pinhole improvement. IOP being normal and anterior segment had no proliferation, and only nuclear sclerosis grade 1 to 2 was seen. The patient had this picture PDR with premacular hemorrhage, almost close to fovea in the right eye, and in the left eye the fundus view is not there. So in this patient, so we only rested the patient with head and elevation. So before that, we have also done OCT in the right eye, so which shows 278 microns, so mild macular edema. And the left eye ultrasound showed moderate vitreous hemorrhage and partial PVD as well. So this patient, we had given laser for the right eye, PRP 3 sitting, and subsequently we did a close follow-up, and PRP laser was considered once the vitreous hemorrhage resolved. But if the vitreous hemorrhage is dense, we can plan to do cataract surgery along with vitrectomy. So because the vitrectomized eyes, the cataract is said to progress fast, so you can consider to do cataract surgery along with addressing the vitreous hemorrhage. So another patient, a 54-year female, so she also had complaints in the right eye with progressive painless dimness of vision. This patient was also having IHD, and both eyes she had undergone 3 sittings of PRP, and last sitting was a year back with still uncontrolled diabetes. This patient had 6/60 vision in the right eye and 624 in the left, improving to 624, and left eye at 612 with 69 improvement. So no anterior segment vessel, nuclear sclerosis of grade 1 to 2. This patient had PDR, so with you can see the tractional component, so in the along the arcades and in the peripapillary area. So in the left eye, so here you can see the superior arcade, some traction. So fovea is still there. In the right eye, there is little bit of threatening the fovea. So the OCT also showed that there was no macular involvement as such. So in this patient, again, it is better to address the, since it is threatening the macula, so it is better to address the traction with the fast vena vitrectomy, and also consider cataract surgery in this patient in the right eye. Left eye we can observe, and we can treat once if it is threatening the fovea. So if we can see that some of the surgeries in diabetic retinopathy patients, so this is one of the patients with vitreous hemorrhage. You can see the cutter, so we are doing truncation as well as clearing the subvelar hemorrhage with backflush, and IPVD, so you see the attachment to the disc, and we are trying to trim the IPVD, so the stump is left behind, and the lasers can be done, so laser PRP can be supplemented. So for if the fractional retinal detachment, so we have now the MRIO cutters which can act as a multitask tool for the membrane surgery, and we also use that in delamination as well as segmentation of this membrane. So here you can see this cutter is used for delaminate this membrane, and we also try to segmentation and clear the posterior pole. So here we are starting the surgery dissection from the posterior pole. So we can also notice the pre-existing retinal tear. So in this patient, so once the membranes were cleared completely, so we can flatten the retina, so by fluid air exchange. And laser the break once the retina is flat. So there are a lot of other surgeries I think we could future speakers will be talking. So to summarize, so if there is a mild and moderate cataract, so assess the diabetic retinopathy status as well as the vision and treat the diabetic retinopathy and cataract surgery only when required. But in case if the severe cataract is there, poor fundus view, so diabetic retinopathy status cannot be assessed. So it is better to do a early cataract surgery in these patients and severe NPDR and PDR, so laser PRP may be considered. So for a DME, so we can either consider modified laser or anti-VEGF therapy. So DME associated with PDR, so anti-VEGF has got a better role. So there are guidelines on diabetic eye care, so which was published by International Council of Ophthalmology, so for the better understanding of the management. So we take home that careful presentation, pre-treatment of the diabetic retinopathy is essential and minimally traumatic surgical techniques to be used. Appropriate post-operative medications and follow-up, so we'll definitely have patients recover excellent vision in cataract surgery, post-cataract surgery in diabetic patients. Thank you.
Thank you, ma'am, for sharing your cases and videos in management of cataract in patients with diabetic retinopathy. Cataract in eyes complicated with diabetic retinopathy is a challenge for any cataract surgeon. So proper documentation is also important to tell about the prognosis after surgery to the relatives and the patient. Are there any questions to the panelists? On to this session. Over to you, Dr. Hema.
Thank you, Shilpa. The next topic will be by Dr. Saravanan sir. That is MIVS choice and recent advances in TRD management. A brief about Dr. Saravanan sir. Sir has done his MBBS in Madurai Medical College 1993 and then DNB 1998 in Regional Institute, Chennai. And sir has done fellowship at Coimbatore Arvindai Hospital and 2002 and continue to work as a retina consultant. And he's also a member of Tamil Nadu Ophthalmic Association, AIOS and VRSI. And sir has presented various papers and participated in various instruction courses. And he has many publications in national, international peer-reviewed journals. And sir has visited Wilmer Eye Institute, Baltimore, New York, Beetham Eye Institute, Joslin Diabetic Center, Boston as an observer. Welcome, sir. Over to you, Dr. Saravanan.
Thank you, Dr. Hemlata, and I'd like to thank Kalpana Madam and Dr. Hemlata for having me here today in this very nice symposium on diabetic retinopathy. So I will just, the basic parts I'll discuss, and probably Pramod sir in the next talk will highlight the more intricate aspects of the surgery. So since Robert McKeemer first introduced vitrectomy in 1970, a lot of improvements and innovations have happened in the field of vitreoretinal surgery. And so the recent, in the last 10-15 years, we have this micro-incision vitrectomy system, or which is always called as minimally invasive vitrectomy surgery, whichever way you want to call it. And after this introduction of this new sutureless technology, a lot of improvements have happened in all these aspects. Port size, from 22 we have gone to 23, 25, and then 27. We also have 13 some of the countries. And we have the improvement in the cutting speed, which translates to safety when you're working near the retina. And then we have the optimization of the vitrectomy port, which makes the what Dr. Kalpana showed in the previous presentation, where the cutter can be used as a multi-utility instrument. So this is a very important aspect of this, is because of the optimized port, where the port has been shifted towards the center. And then we'll be seeing all other things like duty cycle and some of the improvements in the IOP control and instrument flexibility. And I'll not talk too much on the visualization aspect. But this was what I was talking about. From the first introduction of 17 gauge vitrectomy, we have come a long way, and now more popularly in India, most of us use the 25. And people are not very comfortable using, so it's a little bit more flexible. They prefer the 23 gauge. 27 gauge, it's quite good, but I'll show you why it is good. Is that as you get the instruments become smaller and smaller, we call it as port-based flow limitation, where the port size focuses your suction force in a small area, and also that's called the sphere of influence or cone of influence. So when the cone of influence is narrow, the suction force is not spread over a large area. So the safety when you're peeling membranes close to the retina, close to the macula, it is very, very safe. So the smaller the port, the higher the safety. That's what we call as port-based flow limitation. And initially, to increase the cutter rate, we had what we called as rotary cutters, which are not that very efficient at cutting. It was very bulky to hold. But the guillotine cutter was the more popular cutter because of the efficacious cutting. But because of the spring in the system, we could not increase the speed beyond the limit, because the spring action was not, the coil back action could not improve beyond the particular speed. So that was a big limitation in increasing the speed beyond the limit. And we had some other ways of increasing the speed. There was one of the popular machine was the adaptable vitrectomy enhancer, which was attached to the original machine to enhance the speed. And this is just to show how the mobility of the retina is very less as you increase the speed, thereby translating into safety when you're using the cutter near the retina. So once they got rid of the spring, they call what they called as a dual pneumatic. Initially, the forward movement was with the air, and the backward recoil was with spring. So because spring had some limitations, now there's a valve mechanism, so which acts, the air acts in both ways, pushing the cutter forwards and pulling it backwards. So it will call as dual pneumatic cutters. So here the chance of increasing the speeds and also altering the duty cycle became very, very important. So this is, you can see two cutters moving at different, what looks like different speeds, but actually both the cutters are moving at the same speeds. So you can see in the left, you can see the cutter is open most of the time, and on the right, the cutter is closed most of the time. This is called core mode and shave mode, or open mode and close mode. So because of the dual pneumatic mechanism, we can sort of govern how much time the cutter can be closed, or the cutter can be, the mouth can be open. So thereby enhancing the safety or increasing the speed of vitrectomy surgery by gobbling up a lot of vitreous. So if you're in the mid vitreous, you would like to use the open mode, and when you're close to the retina, use shaving off surface membranes, you will be like to be in the close mode. So the machine we call it as core mode and shave mode, but in the duty cycle we call it as open mode and close mode. So also to increase the speed, we have some cutters which have been introduced in the recent times. That's called the double cutting. The original cutters had only one cutting when the cutter moved forwards, but now we have a second cutting when the cutter moves backwards also. This is called double cutting cutters. This increases the speed, but because the port is open most of the time in these, the safety is not relatively not very big difference in the safety as you increase the speeds too much, because most of the time the cutter mouth is open because the double cutting mechanism. So it's not actually safe, because even though the speed is quite high actually. So now we have the newer ultrasonic cutters, which is not taken off due to some limitations, and it is still in sort of experimental mode, not in the market as of now. This is what I was calling about the optimized port. So initially it was a single tip which was made, but now because they tried to move the tip towards the mouth towards the tip by using a separate welded technique. So top lid is actually welded onto the cutter. So this is how they made the port more closer. So the optimized port means that you can introduce the cutter into tighter tissue planes, thereby opening up to multiple sort of mechanisms. Suction can be used like a small forceps, cutting can be used like a vertical scissors. So now we have so many new terms like cutter delamination. Usually delamination meant using horizontal scissors, but now we have what called as cutter delamination. So all this is possible because of the optimized port. There's also the newer design where the beveled cutters or ultrawide beveled cutters, they push the tip even more close to the retina, thereby making it even more functionally easier to use in very close and tight tissue planes. So one of the things we'll have to keep in mind when using all these flimsy, thin instrument is that what you call as counterintuitive motion. When you're moving towards the extreme periphery, the tip actually moves away from the retina rather than closer to the retina because of the we are introducing the flimsy, flexible instruments through a cannula system. So both the flimsiness and the cannula system make this opposite movement, what we call it as counterintuitive motion. I'm just showing a 27 gauge cutter when I'm trying to use it for shaving the temporal vitreous. Whenever I'm trying to go near it, you can see the tip is slightly bending away from the vitreous base. So it's very difficult to go closer. So this is mainly because of the 27 gauge is much more flexible than the 23 and 25, and it's more apparent. The counter-intuitive motion is more apparent in these cases. So when you're using doing vitrectomy surgery for especially for diabetic retinopathy, tougher membranes, so we have so many options. The needle, which is sharp needle, which is used for lifting up thin membranes. You have the heavy forceps, the routine serrated forceps for holding slippery membranes, heavy max grip forceps, and you have the ILM forceps, and you have also the scissors. You also have the vertical scissors. Now in Alcon has got it in 23 gauge. You have the Romex company, which has both in 23 and 25. So whichever you feel the instrument is more safer to use in that particular instant, don't hesitate to shift your instruments. A lot of people now we see that youngsters don't use the scissors much, but don't hesitate to use the scissors, either being it horizontal or be it vertical. If you feel it is particularly useful in that scenario and much more safer to address, don't hesitate, go ahead with this. I'm just showing the both the vertical scissors and the horizontal scissors in action to show the difference between the action in these two instances. So the DRBS study first showed that it is safer to wait especially in non-insulin diabetes patients with vitreous hemorrhage, because the reason was that there are a lot of negative outcomes. 27%, I think close to 27% lost vision, became no PL after surgery. So they advised to hold back surgery in these cases. But from there in the 1970s when it was done, now we have come a long way. So our surgery has become much more easier, much more safer, and much more predictable and better outcomes. So the conventional indications like non-clearing vitreous hemorrhage, diabetic retinopathy, TRA involving the fovea, threatening the fovea, combined RD, iris neostrine precluding a proper PRP. So now we have much more widened scope of indications. So progressive PDR which not responding to your PRP laser, traction in the nasal side where the fovea is dragged towards the disc, vitreomacular traction, epiretinal membrane not allowing the edema to subside, and also some of one more a little bit controversial topics, the traction papillopathy. So if you have vision drop in vision because of traction on the disc, you can do this to relieve this traction from the disc also. So one thing you have to keep in mind is that SACS and phaco, they are two different surgeries, but in MIVS, the surgical techniques are more or less same, only the instrumentation a little bit different. So you do not worry about, don't think that SAC and equating SAC and phaco to MIVS is not actually the case. It's much more simpler compared to phaco, learning phaco. Meaning if you're already doing a sutured vitrectomy, converting to sutureless vitrectomy is not a big difference actually. So this is just showing how to go about doing this. Always have a plan in mind when you see the membranes, the various attachments. Try to make a plan on how to want to go about peeling these membranes. I just this is what I share. What I'm showing is the outside in technique where you move from the outside towards the center. This is the much more preferred technique when you're operating on tough membranes where the membranes are thick and very strongly adherent with thin atrophic retina. So these cases it's better to go from outside in technique where you move the instrumentation from the peeling technique is from peripheral towards the center. But in some case where the membranes are very mild, or like in this case where there is no PVD, you may want to go from inside out where you start from the center and move towards the periphery. So this is the inside out technique. Depending upon what case you are operating and what are the various adhesions which are present, you can decide which is much more easier and much more safer, and decide whether you want to use the outside in technique or the inside out technique. So most of the times we see that PVD is already there, but inducing PVD where the PVD is not there is a little bit tricky in diabetic retinopathy, unlike when you're like doing macro oval surgeries. So using the cutter can be a little bit dangerous in mobile retina. So usually try to use forceps or the sharp needle, the bent needle, which uses the retinal pick, which can be used to induce PVD in these cases. Don't use plain suction like you would use for macro oval surgery when you're operating on diabetic membranes when you want to induce a PVD. So very critical point is the second membrane. I just show this and stop my this thing. This is sort of an invisible or a transparent or translucent membrane, which is usually seen around the area where the new cells arise. And important is that if you are not operating in the sub-second membrane plane, you are not going to have a risk-free, complication-free surgery. So you can just showing a OCT. The top layer is actually the single arrow is actually the PVD. and the multiple block arrows indicate the thin membrane running across the retinal surface. That is second membrane. So again, this is a little loosely adherent second membrane. The previous was a tightly adherent second membrane. This is a vertical scan showing the membrane present from top to bottom of this upper superior arcade to inferior arcade running across the macula. One more case of the second membrane running across the macula from superior arcade to inferior arcade, showing a vertical scan. So it's very critical to do your surgical procedures under the second membrane. So if you're operating below the PVD, it's the wrong plane. So you have to identify and lift the second membrane and then do all your peeling techniques. That way you're going to have a simpler, risk-free and a tear-free surgery. Otherwise you're going to get multiple retinal retinotomies and tears. There is a correct, this I'm showing where a loosely adherent membrane can be induced with cutter only. You can see that I identify the second membrane edge. So usually it changes in color when you start pulling across either with the pick or the forceps or the cutter. So what looks like a tabletop plug addition becomes multiple point additions. So this is one more case where I'm showing a very tightly adherent membrane. So first, after inducing a PVD, cutting through the PVD, you clear the vitreous from that area. And then I'm using a sharp pick to identify the edge of the membrane. It's very invisible. You cannot stain it. So you have to keep dragging, and you'll see that the edge will show up in a different light or a different sheen or shine. Once you start pulling, you can see that now the edge is seen there. Then once I identify the edge, I can use my forceps to address that. If the membranes are loose, the retina is more stable, you can use cutter delamination. If it's tighter and the retina is mobile, you can use scissors to delaminate. So depending upon what is the case scenario in each single case. So disc membranes can also should also be addressed in the same way. Otherwise, the chance of getting rupture of normal arterioles or venules near the disc or peripapillary tears become very common. So when you're peeling these membranes on the disc, your movement of the cutter forceps should be in a tangential, horizontal location, not anterior posterior, but along the surface of the retina, and hold the underneath of the surface and pull it when you go across the disc, so that the leading edge of the membrane will not cause a peripapillary tear. So in this case, it's a very thick membrane, so the second membrane is quite apparent. But in this case, you can see I was trying to remove this membrane for a long time. I was having a lot of difficulty. It's a very thin, transparent membrane. So I realized that once I had difficulty removing this membrane, residual membrane from the disc. So I'm using a pick to identify the edge of the membrane. So once I identify what was causing so much difficulty, comes off very easily. So you can see it's once I start peeling, you'll realize that the membrane is much more visible. It's quite transparent. I had a lot of difficulty. It took me some time to realize that this membrane is covering the discs. So that's why I have a lot of difficulty. So once I identified the membrane, what was came up with within 2 seconds. I had almost spent 10-15 minutes trying to remove this without causing peripapillary tears. So you need not worry about disc membranes causing rupture of the vessels or rupture of the retina, provided you are in the correct plane. So again, showing you a sort of a plug addition which is causing a lot of difficulty. But once I use the pick and try to, you can see a very widely adherent membrane which passes on like a wave as I use my pick to drag that membrane. It's a very large, but very thin, but a very large, covering a large area. So what looked like a tabletop plug addition will become multiple points. So it finally reduces to just 4 points. So plug additions can occur in DR, but they are quite rare. What you see as most plugs are actually multiple point addition. Because you are in the superficial plane, it looks like a plug addition. So this BMT, sorry, I just skip this. This is just showing the arcade to arcade, superior arcade, inferior arcade extending membrane. So here I was having a small cyst at the fovea. I was trying to trim off the PVD and realized that there's a large thin membrane running from top to bottom. So this is very critical to prevent iatrogenic macular hole. If I was in the wrong plane, I would have definitely caused iatrogenic macular hole in this one-eyed patient. So I was luckily able to peel this membrane without causing a hole because I identified the second membrane. So this is very critical to your surgical success. So I can just showing this is the last point. You can see this is the PVD and this is the transparent membrane. Below that is the second membrane. So that is how the second membrane looks like after you peel that. So one more case just showing the pick in motion, how we identify the second membrane. So once we trim off the vitreous and so the membrane edges seems to be here, but the actual second membrane edge is slightly anterior or peripheral to it. So use the pick to identify that. So once you identify that, even though it looks totally like a plug attached to the posterior pole, You can usually use scissors to sort of delament all these small adhesions and remove the membrane without causing a retinal tear. So this is very critical. And this is the last video I'll just show in a CRD patient, a command mechanism RD patient, the transparent second membrane here. So I'm using a pick to sort of drag along the surface of the retina and identify the membrane. So if you don't remove this membrane, after 2-3 months, you'll see that a thick ERM-like membrane is developing over the areas where the second membranes were left over. And this sometimes can contract and open up the previous breaks which are present there. So it's very critical to identify and remove these membranes, especially if it's around the breaks or over the critical visually significant areas like the macula. So if we leave this, after 3-4 months, you'll see a large ERM-like thick membrane developing in these areas where there is leftover. You can see as I start peeling around that whole area, you can see the transparent membrane coming up. And that is how you identify the transparent or translucent membrane. I think I'll stop here. So with the advent of MIVS, we have had a much more easier life compared to earlier days. We have better instruments, better surgical techniques, better illuminating systems, as well as visualizing systems. And that's why we have come a long way. So I think Dr. Naresh pointed out, we are much more comfortable operating in eyes with 6/9 and 6/6 parts vision. So that's how it works around with MIVS. Thank you for your attention.
Thank you, sir. Thank you for covering well. All the videos were well appreciated. As you pointed out, sir, the second membrane identification, especially in vitroschisis. Any tips you want to add on, sir?
So I told you we don't have a proper dice to identify these transparent or translucent membranes. So you can use a sharp pick or a forceps, whichever is convenient. I usually feel the sharp pick is much more efficient because the membranes sometimes can be very thin, and thin membrane is very difficult to hold with forceps. So as you drag along, you can have an idea where it's there and start dragging along the surface of the retina. So once you hook onto the membrane, it will change in sheen, and that will allow you to identify the actual edge, even though you may be in the wrong plane. So by dragging it, you will be able to identify the edge by the change in color of the membrane as you drag. That's how most of the times use. Some people have used triamcinolone and ICG also have seen people using it, but I'm not totally sure whether that really helps in identifying the second membrane. So I don't use any stains or a triamcinolone for that matter.
Thank you, sir. Another question is, sir, like one of the video I saw very vascularized membrane, which while dissection, the very high risk of rebleed, like post-operative.
Post-operatively.
So, yeah, like you want to add on any at the end of the surgery anti-VEGF injection?
Yeah. If pre-operative anti-VEGF has not been done, I usually prefer to add at the end of surgery. So preferably you can inject 3 to 5 days before the surgery. When you sometimes what happens is because we don't see the case pre-operative, sometimes a junior or one of the colleagues advise, and it happens that they miss out or they don't think anti-VEGF is needed. But on the field, say on the surgery, in the surgical field, you feel that there's higher risk of post-operative bleed. So I add on at the end of surgery, I add on intravitreal Avastin usually. So that's what happens.
Okay, sir. A panelist would like to add on any points here. And also one more doubt I have, sir, like whenever we do hybrid vitrectomy, like any precautions regarding we have to take like 23, 25, like we mix upon the gauge.
Okay, hybrid vitrectomy in a proper DR, it is not needed. Like suppose you have a nucleus drop or in a planning combined surgery and you have a nucleus drop, you may want to use, but always change instruments, because when you're using 25 gauge instruments to a 23 gauge cannula, you'll have a lot of leak that can cause a decrease in IOP, increase in bleeding, and a drop in IOP can happen. Also, not only that, you lose out on a lot of BSS. So I don't know, most of the times we use BSS. If you're using ring lactate, it will be cheaper, but we use BSS, which is quite expensive. And if you're going to use smaller instruments through a larger cannula, we have a lot of loss of BSS, and obviously it's going to cost more for the patient also.
Sure, sir.
I just want to know just one question. So I just want to know if there is any role for staining this membrane, especially the second membrane. So has anyone tried staining these membranes?
Staining, madam?
Yeah.
That's what I told. No, I have seen people using both triamcinolone as well as ICG. Also, I have seen one of my colleagues has tried out ICG. He feels it's comfortable, but I don't. When I just saw, I didn't feel it added on to either the ease or the visualization of the membrane. I didn't feel it mattered much. I think Pramod sir can add on that. Have you used any dyes for identifying the second membrane, sir?
Not really. But what Saravanan has rightly mentioned, with the experience, you realize you just add little bit tug. See, the second membrane is always beyond the visible edge of membrane, what you see. And what you see is the moment you give little bit tug, you see some glistening, shiny thing away. You have to look for away from the edge of the membrane. And with that glistening, shining tinge you see, and gently tease it, and you see that stretching effect, you know how far you have to go. That's the best clue, I would say, when you're dealing with this second membrane.
Thank you, sir.
And accordingly follow that.
Thank you, sir.
So, Saravanan, can you just highlight how to suspect that there is a second membrane?
Yeah, that's very important.
This invariably, in a case of diabetic retinopathy, you will have a second membrane. Suppose you are inducing, like suppose in one of the cases I showed from where I was working from center towards the periphery, there was no PVD at all. So no PVD is quite rare, but if you are inducing a PVD, it automatically goes into the subsecond membrane plane. But if you're operating in a plane where already there's a partial PVD, where the vitreous surface is separated from the retinal surface, there you always expect a second membrane, identify that. So in partial PVD, make an effort to identify second membrane. There is no PVD and you're inducing a PVD, usually you go right into the second membrane. So that has no need to make a separate step to identify the second membrane. That's what I have seen in my experience. If you're inducing PVD, no need to identify. If you're already partial PVD is there, make an effort to identify.
So basically, all problems happen when you're not in the correct plane.
Exactly.
Some clues are that if there's a retinal hemorrhage, you're trying to remove that.
When you feel that you're not able to cauterize a bleed, it is obviously below the second membrane rather. So if you're not in the right plane, bleeding is much more difficult to control or stop with cautery. And when you're trying to peel, the whole retina will drag, causing secondary tears. So all these are all much more common if you're in the superficial plane rather than the deeper subsecond membrane plane.
Yeah, very, very tight membranes also. If you are in the right plane, you have removed the membranes, they are going to fold itself and come into the vitreous cutter. So all these clues will tell you that you are not in the right plane. You should look for the right plane, look for the second membranes. So then the surgery is going to be much easier.
Actually, when you try to lift the edge of the membrane,
you can't hold it.
And the base of the membrane where it joins the retina, if the edge is rounded, that means you know something is covering there. Otherwise, what you try to lift the edge and you're seeing a peg-like thing or acute angle, then you know you are at the right plane and probably there is no second membrane there. That's a rather, I would say, best clue. And yes, what Saravanan says, totally agree with you, because most of the time what you talk about tabletop PRD or broad attachments, in true sense, they are not broad attachment. It's like a multiple tiny attachments. And if once you are at the right plane, things are much, much easier. Problem is only thing when the plane is wrong.
Thank you, sir. All the points well taken. Ma'am, you want to add on any question, ma'am?
I just wanted to ask, like, we normally keep doing ultrasound in these patients, and whether we see this schisis and other things. So, like, even intraop OCT, will it contribute for identifying this second membranes and other things?
Evaporative OCT will give an idea, but it's not absolutely necessary. Ultrasound will not give a exact. It will give a large vitreous schisis. It will be identified, but OCT will be the better tool to identify the second membrane plane. But it is not essential to either intraoperative OCT or preoperative OCT. Is not essential to do surgery. Can very well identify these during surgical steps itself. It's not like it's without that you cannot. It's not like a mandatory. That's what I was trying to point out.
Yeah, for the experienced surgeon, it is not maybe for the beginner.
No, same thing is true, because if experienced ultrasonologist is there and he specifically look for, you probably can guess, suspect, and identify, and at least tell you where most likely second membrane is there. OCT, yes, but problem with OCT, because it's maximum you only have now wide scan, not more than 12, and sometimes PRD is beyond that. Then obviously you will not be able to image that. That's a practical difficulty. Otherwise, yes, OCT can. But what happened here depends on person who's imaging, and person should be, experienced enough and specifically looking for it. Then you will be able to get it. Otherwise, not.
Yeah, right.
Thank you, sir. I think we are missing madam here. MPB ma'am. Excellent when you told, sir. Yeah, we'll go on to the next topic that is complex diabetic retinal detachments, how to manage by Dr. Pramod Bende sir. Being an alumni, it's my pleasure to introduce PB sir. Sir has done MBBS MS from Government Medical College and fellowship from Shankar Netralaya. Currently, Director Sri Bhagwan Mahavir VR Services, Chennai. And sir has delivered over 400 presentation in various national international conferences and over 90 papers in peer-reviewed national international journals. Recipient of 7 named orations and special interest being surgeries for ROP, diabetic retinopathy, combined procedure involving anterior and posterior segment pathologies. Over you to sir. Thank you.
Thank you very much, Dr. Hemlata, and thanks, Dr. Kalpana, for invitation. It's nice to be here, and when you see nice, all familiar faces, I'm really happy to see everybody here, though we are all missing physical conferences. So
yes,
it's good. So we'll go ahead. Basically, I think Saravanan has made my job quite easy, and quite a few complicated detachments he already covered. So things are much easier now. So basically, there's no specific definition what is something called as complex RDN. So to put forth few things, what basically technically things are complex for us or difficult to handle, probably you can put at detachment associated angle or iris neovascularization, associated cataract or IOL with PCO causing difficulty in visualization, non-dilating pupil, or we have extensive proliferation, sometime even beyond mid-periphery, and what Saravanan rightly mentioned, no PVD at all right up to periphery, fluoride, excessive fibrosis, either way, no PVD at all, thin mobile retina, particularly what you see in a combined detachments, long standing detachment with a vitreous hemorrhage, reproliferation following vitrectomy, recurrent bleed with anterior proliferation or fibrovascularization proliferation. These are actually, you can group all this probably in a something called as complex detachment in a diabetic eye where you deal with. Certain other issues, what you talk about when you have difficult visualization, particularly small pupil, the options what you have is you can try adrenaline in an anterior chamber or iris retractor or hooks. But generally you want to avoid iris retractor or hooks handling. I'm manipulating the iris because quite a few, these eyes having a iris neovascularization, so risk of bleeding, and these mechanical dilators can induce significant amount of inflammation in a postoperative period. So better to use a wide angle visualization system. Just will come to that in a while. IOL with a posterior capsule haze, you can create an opening in the posterior capsule, or sometime if necessary, you can get the IOL out. And if you have a cataract, previously we used to be hesitant dealing with combined cataract and vitrectomy in diabetic eyes, but we all are now realized with experience it's quite comfortable. We can combine phaco and IOL implantation along with cataract surgery. Most of the time, we do not do plain lasectomy nowadays. So this is just to show the view. This is a small pupil. You look at it, how tiny, maybe around 2.5 millimeter, but this was the large view you get in a fundus. So this is not a diabetic eye, but just for actually this is my, so just for a sake of representation, I pick up this eye. So wide field viewing system gives a panoramic view, even through small pupil, through media haze, and even you can see through even keratoprosthesis as well. And particularly also biggest advantage is you can use it even through when you have a fluid air exchange through the gas. It is excellent view, great depth, easy to operate, and overall obviously it reduces surgical time. Coming to bimanual techniques, basically multifunction instrument facilitates more aggressive membrane surgery, and with MIVS multifunction instruments like this is combined illumination and infusion. As you see, just is a 3-port vitrectomy, but you have illumination and illumination combined. You see excellent view for your surgery is as good as you are using your regular light pipe. So now when you want to use sometime 3-port or sometime 4-port, this is a standalone chandelier. You can put either it's at 12 o'clock or inferotemporal quadrant or inferonasal quadrant, depending on where you would like to initiate your membrane surgery. Basically, you do not want to cast shadow of your light. So probably depending on, just let me go back one. Depending on where you would like to initiate, like membrane dissection, once you have vitrectomy done, accordingly, you choose your cordon where you would like to put your chandelier. And this is because this is what it says. So this is a view through the chandelier. Excellent visualization. So other eye, one eye you can have a scissor, another are forceps, and then scissor along. This is just like a, actually this is a vertical scissor what Dr. Saravanan has shown, showing a bimanual dissection, having a light pipe in an inferotemporal quadrant. So as you see here, weave is excellent, and holding with a forceps in one hand, scissor in another hand, you pick up those pegs very easily, and surgery moves very fast, even though there are many few bleeders, but you don't have to go back and forth before bleeder can cover it. Your posterior pole, you're done with the surgery. But before you initiate this dissection, ensure you have cut the peripheral vitreous, you have identified your second membrane clearly, and then move forward with this membrane. So I used to be very fond of this vertical scissor till again we started with MIVS. This is basically 20 gauge surgery, but just for a sake of principle, how you use a vertical scissor. And still scissors are in use, though most of us are used to with cutter and with a 27 gauge and 25 gauge, but there is a scope for scissor to use in these eyes. This is again 25 gauge now. Similar way, what you saw the scissor, exactly similar way now I'm using cutter here to get those pegs. You lift with the forceps in one hand and identify those pegs, and cutter can be used as a to dissect the membrane as a scissor, sometimes as a pick, and take hardly need of scissor in these eyes. So IRD with the fluoride extensive proliferation, generally most of us are agree, preoperative Avastin we use to minimize the risk of dissect, like a bleeding intraoperatively. But Avastin is not necessary in every case. Case to case, you take a call. If Plorif is not very fluoride, you really do not have to use for every case. What is more important, we already discussed correct plane of dissection. Always prefer periphery to center, except where there is no PVD, no plane available. So probably then you start center towards periphery. If necessary, you can isolate the eye lens. Less vascular part of fibrovascular polarization can be tackled first before going to the more vascular, thicker, and firmly adherent polyps that should be lost to minimize. Otherwise, if you create a break or bleeding at the early stage of proliferation, early stage of dissection, and then you have a bleeding inside and mobile retina, even those less vascular or lesser attachment, sometimes later on with a mobile retina can become more difficult to peel off. So this is the case. These are 27 gauge instruments I use here, and this is like a bevel port optimization. Periphery. This is like a young lady, 18-year-old. Of course, use Avastin. That's why you can see the polyp is now fibrotic, hardly any vascularity, and peripheral truncation was done. And this entire surgery we did using scissor and forceps with having a chandelier inferotemporal quadrant. So just you need to give enough time. You need to have a lot of patience. Try to separate each attachment, just like use a scissor. Most of the surgery eventually turned out to be bloodless for me. See, now the cutter is being used as a pick. As a spatula, gently tap it, gently push, and see those attachments. Sometimes you just little bit tug on it, it separates. Not really to cut, but what I wanted to highlight here, though it is 10,000 cut, not necessarily you have to use every time as a 10,000 cut. In fact, these are the situations where I would prefer cut rate somewhere around 100. This is what dissection I did with 100 cut rate, shaving mode. So cutter is basically being used as an automated scissor. So you hook the pegs with the cutter and activate the cutter. So it's exactly acting as a scissor and cut each and every attachment. Is like you are using sort of machine gun who fires 1,000, 100, 1,000, 2,000 shots in a one pull, and the same one you are using for probably at a single shot gun, something like that. The advantage, yes, you say then what is why I should use a 10,000 cut rate? Unnecessarily, I'm wasting this cutter. The advantage here is because of its bevel tip, because it's a 25 gauge. Okay, so I can use this cutter going conveniently between the plane, between the retina, what the animation Saravanan showed, exactly that's what it works. Things are easy. See, again, this part again easy. What easy for me to just peel up, just move, push one side and it comes up. Also, when you separate these membranes, you have a different angulation rather than folding the membrane fully up or rolling over that other membrane. What you do is at lift in a little bit angle. So yeah, just lift and push to one side rather than directly totally rolling up 180 degrees. Then you sometimes you lose the plane. So you lift this up, just keep that angle constantly, and then you get those. See, plane is so distinct and so clear while dissecting this membrane. And that was part of little bit leftover second membrane, what it was going beyond the edge of the membrane. And see, that is what it goes, and then absolutely almost practically bloodless surgery. But yes, again, these are highly edited videos. You need to go slow. You need to give enough time, and you have to have patience. So things work out well. Unfortunately, this girl has other eye also having a similar problem. We operated other eye also using same injected Avastin followed by vitrectomy. Moreover, other eye had a much larger and flatter polyp, but came out fortunately a similar way. This was the end of surgery, and these are two eyes this girl after at the glass appointment, and she now we have a 3-year follow-up. She is working out fine. Now, when you deal with these young diabetics, nowadays again I realize there's probably very high incidence of recurrent bleed because it's not easy to control diabetes in this young age group. So I started doing again ARC, all these eyes because you want to retain the lens. So extreme peripheral retina, obviously you cannot do that clean dissection. Probably with a curved laser probe, you can manage to some extent, but near aura probably you may not be able to do laser properly. So most of these eyes, if I'm not happy with my laser, I do not hesitate to add on peripheral retinal cryo, ensuring maximum possible treatment in these eyes. What is important is that they need to have a vision. We need try to avoid, minimize the risk of recurrent bleed rather than trying to be conservative. So you have to go outright when dealing these eyes. Fortunately, without having a silicone alley internal tamponade, both eyes I could manage for this girl. This is another case showing pre-Avastin and then having how the polyp regress in a post-Avastin, and this is a post-surgery at 6 weeks. Those retinal folds will stay, but this acceptable outcome in these eyes. Coming to combine RD, need to do a membrane dissection, but problem here is retina is mobile, so there is no count attraction. But once you have a break and once polyps are removed, other part of disadvantage is like any rheumatic detachment and other principles folds grow, good, followed by inter. This is a typical, this similar case Saravanan has shown. Mobile retina, no count attraction, very difficult to peel because you can see subretinal band also indicating chronic detachment. I managed to some extent to peel this membrane, but I also would prefer bimanual dissection, probably using forceps in one hand. What happened here, you can't just peel this membrane all up, just go on peeling. What you do is you lift it, but just maintain that certain amount of tug attraction, hold on that tile and slowly over a period of time, the posterior highlight separates from the retina. Give time, lift and hold it on. But it's not like, again, you do in a rheumatogenic RD, everything you peel up to the aura. What you need to do is just peel little bit amount part of vitreous and you chew it up. Peel little bit and chew it up. Basically, otherwise it will have transmitted traction going away and you'll end up creating breaks somewhere else. Okay. So this is another case just showing the same eye, actually, the remaining part. So ultimately, this is a case obviously not that easy to handle only with cutter. So I do not hesitate. I'm still fond of using scissors, bimanual dissection. Using this curved scissor, they are really, really good now. And just lifting the membrane in one hand, dissecting, see that each peak slowly coming out. But once you are in a right plane, dissection is not that difficult. This is coming up. Managing the hemobleeding intraoperatively is a very, very crucial part. Do not take any bleeder lightly. If you think bleeders are troublesome, please stop, cauterize those bleeder, or even you would raise the bottle light. Rather, I would prefer, generally not very fond of again cauterizing. Try to raise the bottle light, wait for a while, minimize turbulence, and most of the bleeders they stop. And that's what generally we deal with these eyes when having extensive proliferation. Occasionally, you have an extreme peripheral proliferation. Now, these are the situation. What you see, this is again a young girl, having a peripheral proliferation. Now, posterior pole came out very well. I wanted to salvage the lens. And if you try to dissect that polyp, and if you land up in a break, the whole efforts are wasted. Then you land up in a putting oil, and still retina can detach, and then sometimes you land up doing retinectomy and sacrificing lens as well. So if this type of situation, what did I do is, even I do not hesitate using a segmental buckle or encerclage to tackle a peripheral traction. And this girl is now almost more than 10-year follow-up, holding on well, and she is happy and I am also happy. So to conclude, PRDs and CRDs are serious complications of PDR, may develop during active or late stage of PDR. Modern surgical techniques allow probe to be used not only as a cutter, but also as a forceps, scissors, and as a pick, reducing the need for ancillary instrumentations. Bimanual surgery facilitates more aggressive membrane dissection, hence make difficult cases amenable to surgery. Pre-op use of anti-VEGF helps to minimize intra-op bleeding and to achieve more complete removal of the fibroscopal proliferations, leading to overall better anatomical success. However, final visual outcome depends on macular status. So thank you very much for patient hearing. So I'll stop here, and Hemlata, back to you.
Thank you, sir. Thank you for a very nice session. We learned a lot. Sir, my question is, as you pointed out, like all the vitreous sometimes and the polyps we may not dissect up to ora. So all CRD cases should we add on belt buckle, especially in phakic patients?
Well, not necessarily. See what happened again. That is, I would say, pre-operative evaluation is extremely important. Sometimes RD may not extend right up to periphery. Okay, and quite a few, sometimes most of these cases, all of us would have done some laser already, and peripheral retina is holding on quite well. And if you feel there is a PVD in a periphery, okay, so let me put it other way around. Most of the time, combined RD, when you have, there is some amount of vitreous separation, then only polyp will get pulled and then create a break and create a detachment. So case to case, you take a call. If you feel, yes, there is extensive proliferation or some amount of membranes are there which you cannot reach or approach or you do not want to reach, yes, do not hesitate to add on buckle. See, we talk about lot anterior segment ischemia and all those things. I think theoretically, yes, possible, but really incidence is not that high. So purpose here is to get rid of, relieve the traction, because if you don't relieve the traction, either you're going to land up having other additional break in the future or recurrent vitreous hemorrhage because of traction pulling the vessel. So take a call case to case, but if you feel is necessary, do not hesitant to add on. I'll put it that way. Not every case. I won't say every case, but not. Just be open. Keep all the options open.
Yes, one more question, sir. If there is any inadvertent breaks near to the arcades or the peripapillary area near disc, so any tips how to manage?
Well, yes, nice to say avoid break as far as possible. So again, you start somewhere where attachments are not firm. They are isolated. They are thin before coming to a broad area. But by chance, suppose you create a break while dissecting membrane. Now you need to change the direction, because if you, once you create a break and you keep on continuing a dissection, what happens? There is always a tug on the retina, and when this tug is happening at that area where the already break is there, this break start going to enlarge, slowly tearing it further. So what you need to do is now start some other area and now come towards the break. Okay, rather than continuing dissection the same way. So now your direction has to be now, rather than going from break towards other area, you now to start somewhere else, come towards break. So you have minimum tug, or if possible, no tug or pull or traction on the break at all.
Thank you, sir. Any points to be added from panelists?
There's one more question.
About that, very nice videos, and I want to stress the importance of using scissors. The youngsters, they tend to use less of scissors and more of cutter. But in critical cases, I think sir showed in all the videos, almost all the videos you're using scissors. And that's very one important take-home point for all newer surgeons who are learning VR surgery.
There's one more question, Hema, on the chat. So when Dr. Seema has asked what could be the visual prognosis in such cases of diabetic retinopathy, combined RDs or TRDs?
Actually, combined RD, probably I would put what we have a paper from Shankar Netala also. What happened, combined RD, generally patient reports early because sudden loss of vision. So they are relatively fresher than fractional detachments. So you comparative, you look at it, combined RD, probably overall cumulative prognosis when you look at it is better than a fractional detachments. Yeah, but again, it's again case to case because if macula is detached for a long period of time, is already ischemic, if retina is thin, atrophic, associated pale disc, compromised circulation, final outcome generally depends on.
Okay, sir. Thank you, sir. So if there is no questions, we will move on to the next last topic of the session, that is surgical management of subfoveal hard exudate plaques by Dr. Sangeet Mittal. Sir is a director, Vitreoretina, Thind Eye Hospital, Jalandhar, Punjab. Fellowship in VR surgery. Was awarded VT Joshi Gold Medal Award, Best Fellow, MS Ophthalmology from PGI Chandigarh. And sir also has got various awards in EVRS and Physical Poster AIOS Trauma Award, also been given in 2021. J.M. Pava Best Paper Award at VRSI 2009. So welcome, sir. Dr. Sangeet, over to you.
Thank you, Dr. Hemlata, for the kind introduction. And at the outset, I would like to thank Dr. Kalpana and Dr. Hemlata for inviting me to this wonderful symposium. My topic for, start sharing my screen. So is my screen visible?
Yes, sir. Visible. Slideshow, yeah. We can go for slideshow.
Yeah, it's fine.
Yes, sir. Now done. Yeah.
So my topic for today is surgical management of DME with plaque-like subfoveal exudates, and we had a lot of discussion on this in previous talks also. I will share my experience and sincerely hope that after this presentation, PB sir will also have a relook at his approach towards this problem. So my take is keep it stupid simple. The diabetic maculopathy with subfoveal exudates is one of the common cause of severe and irreversible visual loss, and it leads to RPE scarring and subfoveal fibrosis. And it responds very poorly to focal laser treatment, and people have tried using the surgical excision of submacular exudates, but again, this surgery is very technically demanding, complicated, and has poor long-term results. So Dr. Naresh had also pointed out how vitrectomy helps in diabetic macular edema. It helps in the removal of tractional forces at the retinal surface, which in some cases may be very subtle or hidden. It also reduces the oxygen consumption of the vitreous. It reduces hypoxia at the retina. It removes the vitreous collagen on the retina and decreases the VEGF load. This is a small study that we had conducted 3 years ago. It was to assess the role of vitrectomy and ILM peeling alone in the management of diabetic macular edema with plaque-like subfoveal hard exudates, and it's a retrospective interventional case series. So we reviewed records of 933 eyes which had undergone vitrectomy for complications of diabetic retinopathy from 1st January 2015 to 31st November 2018. 74 eyes of 72 patients which fit the inclusion criteria were analyzed. 3-port sutureless vitrectomy with ILM peeling using either an ICG dye or a brilliant blue dye was done, and other procedures like membrane dissection, endolaser, tamponade as needed was performed as needed on case-to-case basis. The inclusion criteria was presence of subfoveal hard exudates preoperatively and preoperatively visual acuity less than 6/18. A good preoperative metabolic control for at least 3 months, that is the HbA1c less than 7, and a minimum follow-up period of 6 months. So this is how we went about, as Dr. Naresh also pointed out, in DME patients, we generally do a wide ILM peeling. So start at the arcades. I generally use a finesse loop in these cases. The ILM is very sticky. And then after raising a flap, you can extend this flap towards the center using the ILM forceps. But as you see, the ILM was very sticky, and we are using here the 27 gauge cutter. Dr. Saravanan pointed out that the 27 gauge cutter, you can go very close to the retina and you can peel off the membranes from the retinal surface, whether it's ILM or epiretinal membranes. So in this case, we use the vitrectomy cutter, and the membrane, which was not easily coming with the forceps, came very easily with the cutter. So the observations were that the mean age of the patient was around 52 years. The sex ratio male to female was almost equal. Mean follow-up was 15.5 months. We had 43 cases of NPDR and 31 cases of PDR. 35 eyes were phakic and 39 were pseudophakic. On OCT findings, we found that vitreofoveal traction was present in 10 of these eyes. Taut posterior hyaloid was seen in 23 of these eyes, and no vitreofoveal traction was seen in the other 55% eyes. So almost 44 patients that we had treated were treatment naive. Only focal laser had been done in 11 patients. 1 to 3 anti-VEGF injections had been given in 15 eyes, and more than 3 anti-VEGF injections had been given in 14 eyes. And record was not available for one of these patients. Pre-operative mean visual acuity was 5/60, and which had improved to post-operative mean visual acuity to 6/24. And improvement was seen in 54 out of 74 eyes. That was almost in 73% of the eyes. And meanwhile, what happened to the other eye status? So two patients had bilateral surgery. 4 were blind of neovascular glaucoma, and one had a burnt out PDR in the other eye. 4 had already had vitrectomy for other problems in the other eye. Meanwhile, 2 worsened after the time we had completed the vitrectomy, and during the course of follow-up, 2 of the eyes, the other eyes, worsened, while the visual acuity had worsened in those eyes. In 50 of those eyes, it remained the same after the surgery and improved in 11 of those eyes. So if we compare the result of the operated eye and the non-operated eye, only 11 of those patients of the 72 patients showed improvement. Otherwise, 50 remained the same and 2 worsened. So mean preoperative plaque size was about 0.531 millimeter square. This was measured using the fundus camera pictures and making a rough drawing over the fundus camera. Over the software was used that was present in the fundus camera to calculate the area size of the plaque. And the mean postoperative plaque size, it has reduced to 0.136 millimeter square. And the largest plaque that we had operated was 1.721 millimeter square. And resorption of hard exudates was seen in almost all eyes. Total resorption was seen in 22 eyes, and partial was seen in 52 eyes. The complications that we faced during this in these eyes was intraoperative retinal detachment in 1 eye, transient IOP rise in 3 eyes, macular hole in 2 eyes, macular scar in 2 eyes, and the most common complication was cataract in those 35 phakic eyes that we had operated within the next 6 months of follow-up. So while operating, what we observed was PVD was pre-existing in 5, that is only 6 to 7% of these eyes, and it had to be induced in the rest, almost 93% of the eyes, it had to be induced. So most of these eyes, there was no PVD, we had to induce PVD. Taut hyaloid was present in 48, that is 65% eyes, although this was significantly important because when we did a pre-op OCT, it was present only in 23 of those 74 eyes. But during surgery, we saw that there was a taut hyaloid membrane which was seen overlying, and this taut hyaloid was very subtle and could not be detected in the pre-op OCT. So ILM peeling came in single sheet in 16 of these eyes, and it was so sticky, it came in bits and pieces in almost 78 to 80% of these eyes. Again, the patients which had completed 1 year follow-up, they showed better results. So more patients had a post-operative better corrected visual acuity after 1 year follow-ups. It meant that the improvement is slow and it takes time. The resorption of these hard exudates take time. And again, during the follow-up. So these are a few of these cases. This is a patient this is a representative case, and you see the patient had 6/60 preoperative vision and a very big hard exudative plaque. Over a period of 10 months, the whole of, after vitrectomy, the whole of the plaque almost dissolved, and the patient's visual acuity had improved to 6/9 in this eye. This is another patient, preoperative vision was 5/60. And 4 weeks post-op, the patient's hard exudate started coming down. And at 6 months post-op, it had completely gone off, and the patient's visual acuity improved to 6/12 in this eye. Again, another patient, 6/36 preoperative, then over a period of 14 months, the patient had a total resorption of hard exudates, and the vision had improved to 6/9. This is another patient, similar patient, almost 12 months post-op, showed a total resorption of hard exudates from the fovea area, and the patient's vision again improved to 6/9 in this eye. This is a representative case in which there was a partial resorption of final visual acuity, but this patient had just a follow-up of 6 months. Maybe the patient did not came later on. Maybe with a period of time, with a period of more follow-up, maybe the small amount of the hard exudates that had been left may have resolved. Can't say. This is another patient. This was a patient who had undergone multiple injections earlier for his diabetic macular edema, but the condition was worsening and his vision was preoperative. This picture was preoperative, and there was a lot of hard exudates now, a plaque like hard exudates. And at this time, the patient underwent surgery, and in due course of time, again, you see slowly at 9 months, the hard exudates have resolved partially. The patient's vision had also improved a little bit. So this was a patient, initial presentation. He was advised to undergo focal laser treatment. There was, after focal laser treatment, there was subfoveal migration of hard exudates. And then at this point, the vision had dropped to 6/36 from 6/, I think the patient had 6/9 at the initial presentation, but due to the subfoveal migration, the patient's vision dropped to 6/36. And at this time, again, the vitrectomy with the simple ILM peeling was done. And you see at 3 months post-operatively, the patient's vision had improved to 6/18, and the foveal that had migrated subfoveally are now improving. So this is one patient which had a largest plaque that I told you, 1.72 millimeter square area. And this patient, though we see subfoveal migration of plaques after treatment of diabetic macular edema, but in this case we saw a reverse migration. The hard exudates moved from the subfoveal space to the extrafoveal space, and the patient's vision improved to 6/36. Again, this patient, this is a patient who had that intraoperative retinal detachment. And though the final visual acuity was 6/60, and though he had a retinal detachment on the table, still you can see after 6 months, the hard exudated plaque has dissolved and has gone off totally. So this was a patient who delayed his surgery, and the surgery was delayed, and at 9 months, you see there was, though the hard exudates had been resolved, but there is the macular scar, the fibrosis which had come on earlier in the preoperative period stayed. So it's always better to operate these kind of cases early. So to get the better, the final visual acuity is better. Again, a small video. It was again a patient of subfoveal hard exudative plaques. We did vitrectomy with the ILM peeling. Again, the ILM peeling was very wide ILM peeling, arcade to arcade. Again, starting with the finesse loop, I just loosen off the ILM at the retinal vein and then do the ILM peeling. This ILM we were able to peel off with the forceps itself. So this is 6 months post-op. Again, the patient has shown resorption of hard exudates and improvement in visual acuity. Coming to the discussion part, people have tried vitrectomy alone with posterior hyaloid removal and no ILM peeling earlier, and they had noticed reduction of hard exudates, which was observed at 3 months, and more than 2 lines of improvement seen in 11 out of 13 eyes. But they have not reported a better vision than 6/60, not seen in any patient, maybe because the result of long-standing exudation. So in our series, vitrectomy was combined with ILM peeling also, and reduction of hard exudates was observed as early as 3 weeks. Visual improvement was seen in 54 out of 74 eyes, and best corrected post-operative visual acuity was better than or equivalent to 6/60 in 56 eyes, out of which 23 eyes improving to 6/24 or better, and 9 eyes improved to 6/12 or better. So probably early intervention in these eyes resulted in a better visual recovery. So what is the role of ILM peeling? So removal of ILM ensures complete removal of posterior hyaloid. Removal of ILM also means that you are removing part of the Muller cell foot plates. Iatrogenic trauma that you are causing to the Muller cells lead to Muller cell aggression, which leads to a cascade of chemical changes leading to the expression of glial fibrillary acidic protein, GFAP, within the entire retinal thickness at Muller cell level, and which this protein helps to fight against the blood retinal barrier breakdown and repairs the interruptions of exoplasmic flow. This also explains the slow improvement in DME after vitrectomy surgery. So ILM peeling also increases the release of epidermal growth factor receptor, which maintains homeostasis, reduces apoptosis, and acts as an inhibitor to VEGF. So there had been reports of surgical excision of hard exudates, Takagi et al. And Sakuga et al. What they had done was they had done vitrectomy with posterior hyaloid removal with retinotomy. They had created retinotomy, then the creation of a serous neurosensory detachment. Then they had used the subretinal spatula to mobilize the hard exudates, then aspirate the subretinal fluid, and then gas tamponade. And they had shown that advantage of clear early cleaning of exudates, thus protecting the eye from deleterious effects of long-standing hard exudates. But other studies have been done, and they have found that this technique is technically very demanding and complicated. And Takaya et al. In Retina 2004, 13 eyes, and they reported iatrogenic macular hole in 3 eyes, submacular hemorrhage in 1 eye, hemorrhage in 1 eye, and optic atrophy in 1 eye. With final visual acuity was very poor in their study. Vitrectomy with ILM peeling alone is a routine retinal surgical procedure with lesser complications, so much better than surgical excision of this hard exudates. The limitation of the study is that it is a non-comparative study, and comparison with surgical excision or an observation alone or with medical treatment alone or intravitreal injections is needed. To conclude, with ILM peeling is a simple and effective option in the management of exudative diabetic maculopathy with plaque-like subfoveal hard exudates. Prospective randomized controlled trials are necessary to substantiate the above findings, and although vitrectomy for subfoveal exudates is not yet a standard primary treatment option, it could be considered in cases resistant to alternative therapies before the damage has occurred. Early intervention yields better anatomical and functional results. Thank you.
Thank you, sir. As we saw many of these cases, that angry looking telangiectatic capillaries were there, sir. So any size of the aneurysm also matter, and should we add on laser in these cases also?
I did not do a focal laser in these eyes. I just did the ILM peeling. In some patients who had PDR, we did do the PRP along with this vitrectomy procedure, but no focal laser in these eyes.
And then the blood lipid level, was there any correlation, sir, in these patients?
All these patients had a metabolic control pre-operatively for at least 3 months.
And they were put on treatment already.
Yes.
Thank you, sir. Any points to be added by panelists? If there is no questions, yes, sir, please.
That's what Sangeet said, because there are a couple of papers suggesting once you do vitrectomy and peel the ILM, that macular area perfusion has improved. That's what's shown in a few papers, but not accepted by everybody. Just this isolated couple of papers, and that is one thing. Second thing is also have been shown. I mean, that's whether how they calculated that improved oxygenation, maybe because of circulation improvement or something else, we do not know. But there's improved oxygenation, probably that adds on. But what happened? Most of these eyes, most of this patient, realizing this is a problem, and put on a not only anti-lipid but intense control of diabetes. Intense control of diabetes, and that is what is more important, helping them out. Of course, vitrectomy, yes, we have to look at it whether it's only vitrectomy that is helping, or because of this combined with intense control, and because Dr. Amod Gupta group has already shown, even if you do not do vitrectomy and you have an intense metabolic control and lipid control, exudates, they disappear. But yes, we need to wait for 9 months, 1 year, sometime 1.5 years, depending on amount of exudation they have, having of results. So here also, whether we do not know is the effect of intense control or effect of vitrectomy. But yes, with vitrectomy probably helping us to speed up the process of absorption, definitely. And as Sangeet repeatedly keep on telling, early intervention, early removal, before the scarring happens, before the structural damage occurs, if we can that works out, probably they have a better prognosis.
Thank you, sir.
Yeah, one more thing, but nobody is doing subfoveal this thing, retinotomy and removal of the exudates and all.
I did, Naresh, I used to do, stop doing. I think we are too late now. I need a few minutes to look for a video. I have video what Sangeet says, exactly what we used to induce the subretinal, put up infusion, elevate the retina, tease out those exudates, and sticky exudates can come out and settle down. But yes, but by the time patient reached to that stage, you all know that structural damage is already, because macular scarring is there, sticky things. Yeah, but we have a video of that also. Maybe sometime later on, maybe I'll just put that video on. But it is there. We used to do that one. Yeah, indication we're always like elevated retina, have some amount of subretinal exudation on OCT, or those we'll have a list of this. Not every case, but
yeah, I was just looking at some videos. People have done 200 degrees retinotomy. They made a flap and really removed the exudates. There is one publication where they have created a macular hole and given a wash.
Coats disease, I think. For Coats disease, they do this.
That is, yeah, people have tried that also, but that is, you do not have to do actually that's significant. Just a small, tiny retinotomy, and that should be okay. I think most of the time it works out well. Actually, you really do not have to make that one, because what happened here, aim is not to remove all the exudates. Aim here is to take out the exudates under the foveal area. That's what. You are not going to just wash entire subretinal space. That is not the purpose. Okay.
Okay, sir. Thank you. So we have one more question. Is there, sir, role of systemic antilipids as an addition in treatment of exudates in macula? Your experience, by Dr. Seema.
I think they are also important. And all these patients actually were on antilipids before they were taken up for surgery, and they were not improving actually with antilipids. Only they were taken up for surgery.
Okay. Thank you, sir. So we have come to an end of the session. And as we all know, our beloved Madam Dr. B.N. Kalpana ma'am is the backbone of this scientific session. And because of
Hemlata,
her,
just 1 minute. Sorry, Hemlata, sorry to
Sir.
interrupt. Just give me a minute. I'll just got that one video. I'll just show this one. Just give me a minute.
Sure,
Okay, just
sure.
30 or 40 seconds video.
Please
Just
share.
that only that one I'll play. It looks a little bit. This was 20 gauge. We stopped using this technique now, but just to show how it works. Yeah, this is. Can you see this video?
Yes, sir. Yes, sir.
Yeah, this is what is like a literally that scar tissue I had to cut with the scissor. So just zoom, and then this is that retinotomy here, one side, and then injected the fluid to elevate the retina. And this is what spatula was Sangeet was talking about. Rub against the retina. You can see is how damaging it will be. So release all those exudates, come out, and once this separated, either you suck out. But here there was a thick plaque. So previously you used to get a subretinal forces which were flat, vertical action. So holding this this subretinal plaque, that is what we took out. So we do not have to go large retinotomy or a periphery. Just what you need to do is a macular area clear. This is what is a subretinal plaque came out, this tiny retinotomy. And this is what you see immediately after surgery, the difference between previous and subsequent retina. And this is a pre-surgery and this is a post-surgery. This is a difference immediately. So counting finger vision has improved to 163 and 6. So it's heroic surgery, all those things. But what is how you get this? But what again Sangeet said, subretinal pool, everything. If you touch choroid, you damage, can the risk of having a submacular hemorrhage, and then you can land up these cases in badly. But yes, we did, and now we realize it's not worth attempting. So stop now. So, but better option is what? Do vitrectomy, peel ILM, and most of the time, yes, it will take time, but eventually get absorbed. Have a good control of diabetes.
Thank you, sir. Excellent video. Now we came to an end of the session. And as we all know, this scientific session being organized by our beloved Madam B.N. Kalpana ma'am, because of her constant enthusiasm and support and allowing all of us to learn, this program was successfully done. So now I request Dr. Kalpana ma'am to give vote of thanks. Over to you, madam.
Thank you, Dr. Hema. So today I'm very great day, especially personally as well as to the Minto. So Dr. Pramod Bende sir, who was my teacher and strict disciplinarian, and I had a great opportunity to learn from him at Shankanetralaya. So experience speaks, that's what I can say. Looking at the videos of Dr. Pramod Bende sir, Dr. Sharavanan, Dr. Mittal, Dr. Naresh Yadav, and Dr. Hemant Murthy, all senior surgeons gave a lot of useful tips, and definitely it makes us go a long way, and we also will be helping more and more patients. So I thank from the bottom of my heart, very sincere thanks to you all, sir, and also on behalf of all the staff and also the director Sujata madam. So to one and all, I thank you. And also the junior speakers who had made a very good contribution, and they also have enriched our knowledge with their experience and slides. So thank you, Dr. Bhargav, Dr. Tirumalesh, Dr. Joshi, and I hope I've not left anyone else, and also our own faculty who have been contributing, and especially Dr. Hema in my absence, like she could organize, rather the credit should go to her for contacting everybody and making this possible. So since I was indisposed and unavailable till today. So thank you so much for all my staff, Dr. Shashidhar, Professor Dr. Vishwanath, and all the young associate and assistant professors. Last but not the least, to all my students and fellows and all the participants, and sitting till here, being along with us and sharing the knowledge and enriching ourselves. So thank you one and all once again, and also the Microvision team for supporting every year again and again in organizing this webinar. Thank you, one and all. I hope I have not left out anybody.
Thank you very much. Thank you.
Thanks, everyone.
Thank you. Have a good weekend.
Thank you.
Thank you. Thank you, everybody.
Thank
Thank you,
you.
everybody. Have a great weekend. Thank you. Thank you.
Thanks a lot.
Bye. Bye. Thank you.
Thank you.
Bye.
Thank you, sir. Thanks to all of you. Thank you, sir.